Three, two,
Monica, whoever
one. We are
whoever
live now,
starts
sir.
their campaign with Rajasthan, they always win.
अरे वाह.
This is addictive. This is addictive. हाँ.
Thank you,
We are
thank you
live
so
now, sir.
हाँ.
Good
कैंपेन
afternoon,
मुझे तो
good
ये
afternoon, everybody.
हाँ.
Now we are starting the webinar. Myself, Dr. Vishal Dave, I am gynecologist and medical advisor to Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this 31st episode of Synergy on the topic obstetric emergencies. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It is my privilege to introduce Dr. Monica Singh. Dr. Monica Singh is President-elect of Bhopal OBGYN Society. She is Founder-President of ISOAP Chapter of Bhopal. She is National Executive Member of ISAR. She is Joint Secretary cum Joint Treasurer of MPIAG as well as Coordinator of Foxy Infinity Committee. She is convener of the present in Synergy Academic Club as well as she was the convener of ISAR Perfection Series and Foxy Symbiosis Series. Over to Dr. Monica Singh.
Thank you very much, Dr. Vishal, for the kind introduction. And it is with great pleasure and happiness that I am bringing forth in front of you the 31st episode of Synergy. हमारे कल्चर में 11, 21, 31 ये सब शुभ माने जाते हैं. So I think 31st episode is going to be a very divine episode because we have got with us two great states, Uttarakhand, the Devbhoomi, and Rajasthan, the Veer Bhoomi. So we are collaborating today with 11 societies of Rajasthan, namely Ajmer, Alwar, Bharatpur, Bikaner, Hanumangarh, Jaipur, Jodhpur, Kota, Pali, Sri Ganganagar, and Udaipur. From Uttarakhand, we have got 6 very dynamic societies: Dehradun, Haldwani, Haridwar, Kashipur, Roorkee, and Rudrapur. So, welcome to one and all. Today, our scientific symposium will be dealing with obstetric emergencies. This is a topic which can never be far away from the heart of any obstetrician and gynecologist, especially practicing in India, because we see it day in and day out. So 4th of June 2026, Thursday, we bring to you the 31st episode of Synergy. I am very honored to have amongst us a galaxy of dignitaries. And for information of all the viewers and audience, we have been granted 2 ICOG points by ICOG. And this session will be recorded on YouTube for anyone who wants to watch it later on. So, Dr. Vishal, let us do the honors and introduce our dignitaries for today. I think Dr. Naren Malhotra sir will be joining very, very soon. So before sir joins, we will we'll wait for 1 minute, Dr. Vishal. Please show us the scientific program. I will just walk you through the scientific program of today, which has been curated very carefully. So I got these 3 speakers together in Indore. In Indore, it was a conference. And I got 3 speakers together. So my webinars are never around any particular state or election or anything. They are around speakers. So whenever I get hold of a speaker who strikes me, I form a webinar. So this is how we framed it. We have amniotic fluid embolism, which will be deliberated by Dr. Charmila Ayavu. And this is a scary sort of scenario, which needs to be dealt very swiftly if we want to save the mother as well as the baby. Maternal mortality auditing is of interest to every state because there are some states in India who have got very high maternal mortality and some have reached a mortality MMR of less than 100, even less than 50. So today we have the auditing discussed in detail by Dr. Jayam Kanan ma'am, who is authority on this subject. And last but not least, we have a very interesting panel discussion on venous thromboembolism. Again, a very, very common entity, often diagnosed clinically, sometimes misdiagnosed, sometimes missed, sometimes we lose a patient. So this panel discussion will be moderated by Dr. Priya Kanappan, and we have a host of panelists drawn from all over India. So after this, we come to our welcome of our guests. I think we will introduce Dr. Naren Malhotra sir after about when sir joins. So we go to our Foxy dignitaries for today. The Foxy dignitaries for today are Dr. Anju Soni ma'am, who is the Vice President Foxy West Zone. I think madam is also yet to join. So Virul, please make a call to madam
Yes, ma'am.
Anju Soni ma'am. And we will introduce madam after she joins, but Priya is there. So we have got another Foxy dignitary amongst us, who is a very, very dynamic Foxian, as well as chairperson of the Foxy Family Welfare Committee, Dr. Priya Gupta from Kota. So Dr. Priya Gupta is not only a very friendly and very, very capable Foxian. She is a senior consultant obstetrician, gynec laparoscopic surgeon, and infertility specialist working in a very busy hospital in Kota. She is an alumnus of Jabalpur Medical College and BJ Ahmedabad, a gold medalist throughout. She has been the president of Kota OBGY Society, and she competed in a very closely contested election, and she became the chairperson of Family Welfare Committee of Foxy, and she is working very passionately for this committee. So, Priya, welcome. We would like to have
Madam, thank you so much, ma'am. Am I audible?
Yes, you are. Yes.
First of all, good evening, everyone, and my sincere regards to all of you. Thank you so much for making me part of this 31st episode of this symposium of synergy. I think I've been watching this symposium since a long, long time, and I'm already fascinated by the amount of efforts Madam takes to curate the scientific program, and that is what is more touching about it. So I'm really glad to be the part of this symposium in this 31st episode alongside distinguished seniors like Naren Malhotra sir. I could see Veena madam. I could see all my esteemed distinguished seniors and the esteemed colleagues from different societies of Uttarakhand and Rajasthan. So my greetings to you. Sarveshwari ma'am is also here. Good evening,
Yes.
madam. Actually, I've logged in through mobile, so I'm not able to see everyone. But I'm really delighted to see that this symposium is focused on the highly relevant obstetric topics, which are really critical in the management of so many patients which we encounter. These emergencies are really very severe, sudden, and serious complications come up either during pregnancy, labor, or immediately after the childbirth. And that is the time we require immediate medical attention. So, prompt diagnosis and the treatment both are essential. And this is a topic of amniotic fluid embolism. It is very tough to diagnose. I think in my 20 years of practice, just a single case I can say with confidence. Though I've seen many, but I was really able to diagnose one with utmost confidence. So this is the irony about these particular topics.
Yes.
So I'm really glad to be a part of this symposium. And I think these subjects are of immense importance in improving the maternal outcomes and strengthening our evidence-based clinical practice. So I really congratulate the organizers, Monica Madam and Randi Sir also, for bringing together experts to share the knowledge, their experiences and best practices. I think Jayam Ma'am is the teacher of teachers. Charmila Madam, I really have so much awe and respect for her regarding the academics. And Dr. Priya, she has chosen the topic of venous thromboembolism. It's again an excellent one. So I'm really confident that this academic webinar or deliberation will be a great benefit to all of us, and this will contribute meaningfully to a safer motherhood initiatives. So wishing the symposium a real grand success and best wishes to Monica ma'am for her future endeavors. Best of luck, madam. Thank you.
Thank you so
Thank you,
much.
Dr. Priya. Thank you.
Thank you for your kind words and your gracious presence, Priya. So now we go to our stars. So every state we select, we also select a star from that state. So we have amongst us the star of Rajasthan, Dr. Veena Acharya ma'am, and the star of Uttarakhand, Dr. Sarveshwari ma'am. I don't know who is senior. I think Veena ma'am is senior.
Yeah.
So Vishal, we will first introduce
She
Veena.
should come first.
Yes, I'm so sorry for my lapse, madam.
No problem, no problem.
So, madam, for
Only
us,
1 year difference between we two.
so
I'm
madam,
an immediate junior.
but you are both stars for us. So when I was forming this program, the first person, whenever Rajasthan strikes me, the first person is Monica. I called Monica Gupta. Monica, kya karna hai? So she gave me a complete outline in 5 minutes. You have to do this, you have to do that, you have to talk to her, you have to this. You cannot do the program without Veena Acharya ma'am. So that is when I, called madam. I took her blessings, and I'm thrilled to have her amongst us. We all are blessed to have her amongst us. Madam is teacher of teachers. She is a mentor to many. She is a stalwart of Rajasthan. Madam has been the ex-professor and unit head in the Department of OBGY at SMS Medical College, Jaipur, and MGM College, Jaipur. Right now, she is the senior consultant and head of OBGY and preventive oncologist at Rajasthan Hospital, Jaipur. Madam has been the chairperson of ICMCH, Narchi, India, president of Rajasthan branch of Narchi, Jaipur Obsgyny Society, ISCCP and Fertility Society, patron of the Association of Gynae Endoscopic Surgeons of Rajasthan, national executive member ISCCP, and director of Colposcopy Center and national executive ISCCP. Madam has been the recipient of the Chikitsa Vibhushan Award on Doctor's Day, 1st July 2018, Appreciation Award by Foxy in postgraduate CME, and invited faculties to several international events. Welcome, madam. We need your blessings, madam, and words from you, ma'am.
Very good evening to all. It is matter of great pleasure and for me to join today's webinar. It is really wonderful to be see all the dignitaries and my near and dear. And I'm really thankful to Monica. You have asked me to be one part of your such a wonderful webinar, because this is what topics you have chosen is really need of the hours. And it is rightly pointed out by doctor that it is the obstetric emergency. If we are discussing and we are discussing, although we all know the amniotic fluid embolism is rare, but it is a life threatening. So we should be very, very attentive when we have diagnosed the amniotic fluid embolism. And we have the very good speakers who will enlighten us on the very important topic, how to manage, how to approach. And one thing always remember that whenever the patient by any way in shock, we must be very careful in the first few minutes of the first golden hours. So that is the key point of the everything when we are dealing with the obstetric emergency. If you will manage the patient in the first few minutes in the first golden hours, that is will the so the rightly first and foremost is important, the rightly timely diagnosis, early management and early treatment, then you will save the life of the patients. And I'm really thankful to Monica. You have invited me in such a wonderful topic. All the best, Monica. And by this way, we will be continuously in touch. Thank you, Monica.
Thank you. Thank you so much, Veena ma'am. Thank you for your blessed presence. And you have set the ball rolling with your kind words and your blessings. And now I would like to invite our star from Uttarakhand. So Sarveshwari ma'am is a person who is very, very dear to me. We met first time in Dehradun, and there was a conference by Dr. Ritu Khanna where I met madam. And before I met her, I had heard very good things about her. So when I met her, it didn't seem that I'm meeting her for the first time. She's such a warm person that instantly you are drawn towards her. So after that, we have been constantly in touch. And madam is a very highly placed government official, retired director, medical and health services of UP, and Uttarakhand Ratan awardee, but so humble, so down to earth, and very loving. Madam has been the founder and managing director of the Kishori Foundation, a pan India NGO, which focuses on screening programs and awareness camps in all the urban and rural areas of Uttarakhand for early detection of breast cancer and cervical cancer, which is of such great utmost importance that it is now entered government programs in all the states. Madam has been the Director of Medical and Health Services of the Government of UP. Just now we were discussing how Madam has worked extensively in Allahabad, now Prayagraj, Gorakhpur, and then shifted to Uttarakhand, where she belongs. So her chief areas of interest are oncology. She's also been, a very keen colposcopist at the Regional Cancer Detection Center at TB Sapru Hospital, Allahabad. She's organized several camps in MLN Medical College, Allahabad, and also been doing projects for AIMS Delhi on hypothyroidism. She holds life membership of several societies. And Madam, we are honored to have you amongst us, and we need your blessings, Madam.
I'm Naren sir as well.
Uh,
Good evening, sir.
Thank you, Monica. So nice word you have said about me. I don't deserve that much, I think so. So let me thank all the organizer of this webinar for giving me this opportunity to be here with so many learned persons. Regards to Dr. Mehrotra. He's just coming. So, Anu Soni, I met her in Jaipur, and Dr. Priya Gupta. I have heard her saying good words about the emergencies. So, I'm really elated that my teacher is here, Dr. Veena Acharya, who taught me how to use the HPV vaccine, how to protect the girl from the cervical. If you give to a girl, she will be protected in her life. So, ma'am, naman to you. And I know what to say about the speakers. They are my favorite. Both of them who are speaking and the moderator who is taking the moderation and the subject, the topic which Monica you have chosen, they are really wonderful. I think they are need of the day. Every one of us should know about them and should know how to manage them. So today, the speaker are going to say about the new guidelines of the subject, and I think we all will be benefited. It's not only we are benefited, not faculty. I think all the delegates will be benefited. So I congratulate all of faculty, all of delegate to have this academic feast which Monica has arranged for us. I will not miss Zandhir. I will take your name also. Don't say that I'm taking the name of Monica. She's very close to me, I know, but without you, she's nowhere. You are the force behind her who has pushed her like do this and do that, and she's doing whatever you said to her. And I wish Monica all the best. I really welcome all the guest speakers, all the I can see Dr. Mehrotra, I can see Anju, namaste, and I can see them here, and all the guests of honor and the special guests, especially, where is he? I can't see him.
Yes,
Uh,
yet to join.
he's not here, but he's of your field, Monica. ठीक
Yeah.
है so I love to see Meenu is here, and she's a star doctor of Dehradun, I must say. And whole of the Uttarakhand is Vidyu Survey is here. And I tell you, Monica, the girls in Uttarakhand, they are doing a lot. I'm amazed by their work which they are doing at Uttarakhand. I will not take much time. So, with the team of Uttarakhand, I brought many, many blessings from Devbhoomi Uttarakhand for you, Monica, and all the best for the coming election. एक बात बोलते हैं विजयी भव जय हिंद
Thank you so much, madam. Thank you. Those were such kind words and all blessings. Today, we are very, very honored to have amongst us Dr. Professor Naren Malhotra, sir, as our
Yes.
guest. So a big applause for Sir. Sir has joined as chief guest today, and Sir is logged out.
No, ma'am, he's here.
Okay, okay.
Anju ma'am is also there, ma'am.
Good evening, sir. Welcome, sir. And as long as Foxy is there, Naren Malhotra sir is there, and Malhotra family is there. Last program we had with us Dr. Jaideep Malhotra ma'am and Niharika. Today we have got Naren Malhotra sir with us because sir that time he was traveling. Sir has been the past president of Foxy, our beloved organization, past president of ISAR, and various other organizations. I have learned the ABC of ultrasound from Sir. Sir was the motivating factor, motivating person who led us through the journey of ultrasound. His workshop I attended at PGI Chandigarh, and then I went to his Ian Donald course in Clark's Hotel, Agra, when I was full term. So that is his power, as a teacher. And you name anything, and Sir is ahead in that. So I can read Project Positive. Sir is the teacher positive, the leader positive. He is the positivity of Foxy. And there can be no other person who can be as dynamic, as positive, as motivating as him. So his dynamism is the testimony to the great family he has got together, not only his immediate family, but the family of Foxians. So, sir, we are blessed to have you amongst us. And I don't want to speak when you are there, sir. The stage is all yours.
A very good evening to all of you. It's indeed a pleasure to be here in this interesting, very, very important webinar. Thank you for those kind words, Monica, and wish you all the best for your future and your endeavors. And we look forward to young people like you to be actively involved in the Foxy leadership so that we can have a new dynamism in all these committees. And then, of course, it opens up venues for everything to go even higher and higher. Now, this meeting, which I see, is really, I mean, you have all the experts, you have seniors, you have very reputed speakers and obstetric emergencies. So, all of us need to be trained, even if you're not doing obstetrics, to train in obstetric emergencies. And we've been doing these training programs all over India, what we call as the obstetric drills, the PPH drill, the eclampsia drill, the preterm drill, and especially when India is the capital of PPH, PIH, and preterm labor and diabetes, because of our sheer numbers, we got huge numbers of all these problematic obstetric cases. And today, I'm sure the deliberations will go far in making our understanding more clear and how do we clinically handle all these. So, congratulations, all the best to all of you for a wonderful, wonderful evening of this webinar. Thank you for inviting me.
So thank you.
Thank you, Naren, sir. Thank you, sir.
Sir. It means a lot, your presence in the program. Thank you, sir. Thank you, sir, for your blessings and for being there. And now I invite our Foxy dignitary for today, Dr. Anju Soni ma'am. So Dr. Anju Soni ma'am is also the face of Rajasthan. She is the Vice President Foxy from Rajasthan. I have always related ma'am to Menopause Society also. So madam has held both the organizations together like, like a glue. And she is very attractive, very elegant. So she has made us believe that Foxy is beautiful. When we see people like Anju Soni ma'am, we believe that Foxy is beautiful, and it is indeed beautiful. So, madam, all regards to you. Your achievements are commendable. I have seen you the chairperson of HIV committee. Those were our baby steps into Foxy. She's led the Jaipur Obs-Gynae Society. She is actively managing her group of hospitals in Jaipur, as well as, an active dynamic gynecologist. So, madam, need blessings from you. Always seeking your blessings, Anju ma'am.
Good afternoon to each and everyone who is present here. Dr. Narendra Malhotra. Just now, I heard Dr. Saraswati, Dr. Veena Acharya, all dear fellow presidents of in Rajasthan societies and secretaries of Rajasthan society. It is really, really beautiful afternoon today where I think only Monica can do this wonder of collecting each and everyone on one platform. Congratulations to you, Monica, for such a hard work and collecting everybody here. And the and also you have collected Uttarakhand society. That is also a great thing. So you have been able to gather all of us together. जैसे माला के मोतियों को तुमने पिरो दिया है, ऐसे हमको सबको पिरो दिया है. Lot of effort and labor by you. And I want to really congratulate on your all the efforts and the labor you are doing. I'm sure you will be getting the fruits of your labor in coming days to come. And I would not like to miss the calling the names of none other than Dr. Aruna Kumar, Dr. Archana Mishra, and dear friend Rachana Dubey, who has, we only recently met and we gel very, very closely. So thank you for inviting me here. And the topic you've chosen is again a very, very beautiful topic because it is what every OBGYN, comes across unexpectedly. So we should be ready with these emergencies all the time till we are practicing. And I'm sure all of us will get a lot of new insights from the webinar today. So my best wishes are you for the webinar of today as well as for all your future endeavors. I will not like to take any more time and come in between the academics which you have planned for today. So best wishes once again. And thank you for inviting me here today.
Thank you so much.
Thank you.
For being the foxy dignitary of the evening, madam. Thank you so much. And Priya also. And now I would like to come to Madhya Pradesh. We are traveling the whole of India. We've got speakers from Tamil Nadu. We've got societies of Uttarakhand. We've got societies of Rajasthan. We are sitting here in MP. So now we take the great pleasure of introducing the dignitaries of Madhya Pradesh. Dr. Virul, has Kumar Madam joined? Dr. Aruna Kumar, Director Medical Education. I saw somebody from her office logging in. Okay. So we will go to Dr. Our dignitary. Madam is joined?
Yes, ma'am. Aruna Kumar, ma'am.
Ma'am is joined?
Yes, ma'am.
Okay. So I take great pleasure in introducing before you the Director Medical Education, Government of MP, our own Dr. Professor Aruna Kumar, who's also the former Dean and Head of the Department of OBGY at Gandhi Medical College, Bhopal, which is my alma mater. She has been the former hospital superintendent in Sultania Zanana Hospital. She has been the force which has helped the hospital together and introduced several new projects in the hospital very dynamically. She is a keen obstetrician and a keen academician. She has been awarded the State Health Navchar Award many times. She's been the national trainer of EMOC and has led the hospital in the COVID times. She's also been a big part of the PPH bundle project, which was put together by Harvard University along with MGMC Wardha, and a study on COVID surgeries by Multi-Center International Cohort in Birmingham University. Madam is the advisory board member of all societies, of all organizations, heading the MP government in Safe Motherhood Committee, PCPNDT, State Quality Assurance Cell, PG and UG Advisory Committee of Bhopal University, and Maternal Death Review Committee, about which she is very passionate. So welcome, madam. Ma'am, are you there? Ma'am, can you please start your video? Dr. Virul, I can't see, madam. Okay, so we will wait for Madam. Dr. Virul, can you please make a phone call to
Yes,
Dr. Aruna Kumar?
yes, ma'am. Usually she joined, ma'am. Just
Yeah, I did see somebody logging in from her office, but then the picture went. So now I would like to invite amongst us Dr. Rachna Dubey, ma'am, our dignitary from MP. Can I have her CV, please? Dr. Rachna Dubey is the Director Health IEC and State Nodal Officer for Preventive Gynec Oncology and Infertility. And she is the dear daughter and of Dr. Professor Meera Agnihotri from Kanpur. Madam has been a very, keen participant in all our webinars. She has been in our webinars several times. She is responsible for taking the health services in the MP government to another level. There is always something new in her mind, whether she wants to start the preventive gynec services or she wants the government to step into infertility. She is the in charge for the state-of-the-art Center for Preventive Gynec Oncology, and she started infertility in one of the largest government hospitals of Bhopal, that is the government KNK hospital.
Thank you, Monica.
Rachna ma'am, the stage is all yours, and we are so honored to have you amongst us.
Thank you so much. I'm really delighted to be a part of this 31st episode of Synergy program. This is a highly attended platform that has actually consistently addressed to various important topics in Obs and Gynae. And I'm also very honored to be a part and share a platform with the distinguished experts like Dr. Naren Mehrotra sir, the beautiful Anju Soni, as you mentioned, Dr. Priya Gupta, Dr. Nautiyal, and Dr. Veena Acharya. So we have been meeting everybody in conferences, and it's a big family. And if you talk about today's session, it's particularly very significant as it actually focuses on reducing the maternal mortality. That's an area that actually requires sustained attention, especially if you talk in perspective to Madhya Pradesh, where there is still considerable scope for improvement. We look forward to hearing Dr. J.M. Ma'am's insight on Kerala model, which Monica was telling me that she would be talking about the Kerala model. And I'm really interested in hearing, because we in Madhya Pradesh want to reduce it to at least the national level. And where she will be talking about Kerala model that has really gone down below the national level. And equally important will be the discussion on the maternal mortality audit also, which is a critical tool in identifying the gaps in care, understanding avoidable factors, and maybe strengthening health system and implementing the evidence-based corrective measures. That's a robust maternal mortality audit actually processes and plays a very important role in transforming and improving the maternal health outcomes and saving lives. I would like to congratulate Dr. Monica and her tireless efforts for organizing such valuable educational programs despite her demanding schedule. And I do keep telling her also, how are you managing all these things? So she says, ma'am, ho jata hai, hum dono kaam kar lete hain. And my appreciation goes to Dr. Randhir, who's a regular supplier of mangoes to me. And and Dr. Randhir, I would also like to tell that behind every successful woman, there is a man who keeps saying, go, jao, ji lo apni zindagi, I am behind you. And also Dr. Butkar and the organizing team for highlighting this crucial subject. And thank you very much. And we look forward hearing to all the beautiful and wonderful experts. Thank you very much.
Rachna ma'am, I know how busy you are from morning 4 o'clock to night, and always on her toes. And I'm sure now she's got a busy OPD to attend. But thank you for being there. And
My
you,
pleasure.
Thank you, Rachna ma'am.
All the
Thank you, ma'am.
best.
Thank you.
you and Meera ma'am mean the world to us, ma'am. Thank you so much.
My pleasure.
And now I think Dr. Archana Mishra also was there, but now I can't see her. So we move on to our guests of honor. Our guest of honor, Dr. Leela Vyas ma'am, is yet to join, but I can see our dear Dr. Meenu Vesh ma'am with us. So we will introduce and welcome the President ISAR of Uttarakhand chapter of ISAR, that is Dr. Meenu Vesh. She has led ISAR in Uttarakhand from the front, and we have seen her work since several years. She's a senior consultant at Meher Hospital, Dehradun, a very sweet and approachable person, a keen academician, a regular in conferences, and has got lots of ideas about how to take ART and fertility services forward, not only in her state, but at the national level. So, Meenu ma'am, we are honored to have you as guest of honor, and ma'am, few words from you.
Unmute her.
A very warm good evening to everyone, to our chief guest, to Foxy dignitaries, Chief Guest Dr. Narendra Malhotra, Foxy dignitaries, Dr. Anju Soni, Dr. Divya, and star of the Uttarakhand, Dr. Sarveshri ma'am. Dr. Monica has already spoken the nice word about her, the right word about her, and Dr. Veena Acharya and dignitaries of the MP states and all the special guests and our very eminent speakers, faculty members, and all the colleagues and all the young brigades. So congratulate Dr. Monica for such a lovely collection of good friends, and we are able to see a lot of good friends here. So thank you, Dr. Monica. And I congratulate Dr. Monica and along with Dr. Monica to Dr. Radhir also for selecting such a good topic, which lies which is the heart of the obstetrics care, which is the heart of the safe motherhood, that is the obstetrics emergencies. The topic, the Monica you have chosen, that this is the thromboembolism, venous thromboembolism, and amniotic fluid embolism. It looks that even after the advancement of the obstetrics, the sudden emergency arise, and we need to have preparedness and teamwork, and we have to need to have evidence-based decision making. And besides that, even the maternal mortality audit, which the topic you have taken, it is very important topic, and the audits teach us, it gives us a lesson of the adverse outcome of a pregnancy, and every lesson teaches us how can we improve the maternal outcome. We have got a wonderful speakers, Dr. Chamila and Dr. Jayam. They are excellent speaker, and their expertise and evidence-based approach in obstetrics critical care is very much respected all over in our country. So very good topic, Dr. Monica, Dr. Ranveen, you have chosen, and through this webinar, we all will transfer knowledge into readiness, and readiness into improving the maternal mortality rate. We will be able to improve maternal mortality rate through this webinar. So I again congratulate Monica, and I wish all the best wishes for your future endeavor. Thank you, Monica, and thank you for this webinar. I will be attending this webinar. This is such a good and important topic to learn. Every time we learn something. Thank you very much for inviting me, for giving me opportunity to be part of this academic collaboration.
Thank you so much, Meenu ma'am, for the nice words.
Thank you, Meenu ma'am.
Thank you.
And now I would like to introduce our special guest. Dr. Rohan Palshetkar has not joined till now, but we will wait for him. And Monica Gupta is here. Dr. Monica Gupta, Dr. Sangeeta ma'am is not joining today evening because of some family issues. So we will just pay regards to our guests of honor, Dr. Leela Vyas ma'am and Dr. B.S. Jodas sir, who is also Secretary of Jodhpur OBGYN Society. Our special guests for the evening are Dr. Rohan Palshetkar and Dr. Monica Gupta. Dr. Monica Gupta is a tireless worker, a tireless Foxian, who is also coordinator West Zone of Foxy Public Awareness Committee. She is one of the key persons who got this webinar together. A very, very helpful individual, a very hardworking obstetrician gynecologist, very good at her work, very good at keeping relations with all seniors, juniors, and colleagues. She's working in Daksh Hospital, Alwar. She's busy from morning to night, but very helpful at the same time. So thank you so much, Dr. Monica. Few words from you, please. You're muted, Monica. You're muted.
Thank you, Monica. We have shared the same name, and there's a bond of love and affection between us, and you made me feel proud because I'm sharing the stage with so many stalwarts to whom I always look forward. And you made my dream true. I'm also one of them now. And thank you for making me the special guest, though I don't have that much ability. And this academic program is excellent. Obstetric emergencies always a nightmare for the obstetrician, even though how much we are experienced. But whenever anything happens, we are really into a shock, into a terrible condition. And at that time, if we have got repeated learning, we can manage the things proper. Because if we are not reviewing the things properly, we may forget few things when the emergency arise, because they arise not very frequently, only now and then we are in a dilemma what to do and what not to do. So, and Charmila madam, JM madam, they are both an excellent speaker. Dr. Priya will be conducting a very nice panel, and I'm looking forward for the webinar to continue. And best wishes for your future endeavors. I'm always with you. Thank you very much for making me part of this program.
Thank you so much.
Thank you, Dr. Monica Gupta, ma'am. Thank you.
Thank you, sir. Thank you for your efforts also.
So I really appreciate your patience for being all of you being here for introduction of dignitaries. And now a little, just 5 minutes we will take to give our thanks to all societies. We start with the Veer Bhumi of Rajasthan. Rajasthan OBGY societies are 11 in number. We have got Ajmer OBGY Society headed by President Rama Garg ma'am. She has joined our program. Welcome, madam. Madam is a senior obstetrician and gynecologist from Ajmer and also an alumnus of R&T Medical College, Udaipur. And she has been always helpful in all our endeavors, giving her contribution and kind advice. Welcome, madam. Her secretary is Dr. Ruchika Vijayvargiya. Next, we have got Ajmer OBGY, Alwar OBGY Society, headed by President Dr. Abha Sapra, madam, and Secretary Dr. Charu Johri. She is working in Indra IVF, Alwar. Next, we have got Bharatpur OBGY Society, headed by President Dr. Ritu Gupta and Secretary Dr. Anil Kumar Goel. Thank you to both of you. Next, we have got Bikaner OBGY Society, headed by Senior Gynecologist Dr. Sudesh Agrawal ma'am and her Secretary Dr. Rachri Chalia ma'am. Next, we have got Hanumangarh OBGY Society, headed by Dr. Renu Sethia ma'am, who is Director Bombay Hospital Maternity Hanumangarh. And her secretary is the very dynamic Dr. Namrata Bansal, working in Batinda Surgical Hospital. Next, we've got the Jaipur OBGY Society, headed by Dr. Asha Verma ma'am as president and secretary Dr. Indira Lamba. Next, we've got Jodhpur OBGY Society, headed by Dr. Kalpana Mehta as president and secretary Dr. B.S. Joda sir is also a guest of honor. Kota OBGY Society, headed by President Dr. B.L. Patidar, who is working in the Government Medical College Kota as a professor and unit head. And his secretary is Dr. Kumkum Gupta, who is also in GMC Kota. Next, we've got Pali OBGY Society, headed by President Dr. Ashok Naniwal, and his secretary is Dr. Shiv Charan Meena. We have got Sri Ganganagar Society, headed by President Dr. Sarita Upneja, and her secretary Dr. Savita Lalgadia. And last but not least, we've got Udaipur OBGY Society, headed by President Dr. Prakash Jain and Secretary Dr. Pradeep Vandwal. The Dev Bhumi Uttarakhand, I wanted to speak a lot, but because of shortage of time, I'll not be able to cover what Uttarakhand means to us. But it's got beautiful societies. Dehradun is my place where I did my schooling from. President is Dr. Rita Dhawan, madam. Welcome, ma'am. And her secretary is Dr. Sangeeta Maheshwari. We've got Haldwani OBGY Society, headed by President Dr. Madhu Kiran, ma'am, and Secretary Dr. Gunjan. We've got Haridwar OBGY Society, the Holy Town, headed by President Dr. Seema Gupta and Secretary Dr. Manpreet Kaur. Kashipur OBGY Society, headed by President Dr. Tulika Pathak and Secretary Dr. Vibha Mehrotra. We've got Rudki OBGY Society, headed by President Dr. Abha Agrohi and Secretary Dr. Preeti Arora. And last but not least, the Rudrapur OBGY Society, headed by Dr. Pavanpreet Kaur and Secretary Dr. Surbhi Singh, ma'am. I can see Dr. Ritu Gupta, Dr. Surbhi Singh in the program. Even Rama madam was there. Madam, would you like to speak a few words? Ritu ma'am, please unmute. Rama ma'am was also there.
Yes, ma'am.
Ritu ma'am, would you like to speak to us? Rama ma'am, good evening.
Hello.
Namaskar.
Good evening, everyone.
Ji ma'am.
It's very nice to see you all, and we should start that
Okay, madam. Okay, thank you so much for your blessings. And we are running a little late. So before I start the program, I give thanks to my brilliant coordinators. Program coordinators are Purva and Virul. Virul is there with you. She must have contacted all of you. And I hand over the session to Virul to start the talk one by Charmila ma'am. Good evening, Charmila ma'am. Namaskar.
Good evening, Monica.
Good evening, everyone. Now we are starting our session one, which is on the topic amniotic fluid embolism. For that, we have panel of chairperson with us. First, we have Dr. Anupama Ravi Patela ma'am. Ma'am is past president Rudrapur Society and also owner at Rudrapur Hospital. We welcome you, ma'am. Next, we have Dr. Neeraja Pant ma'am. Ma'am is past secretary at Rudrapur Obsgenic Society. We welcome you, ma'am. Next, we have Dr. Asha Verma ma'am. Ma'am is president at Jaipur Obsgenic Society. We welcome you, ma'am. Next, we have Dr. Indra Lamba ma'am. Ma'am is secretary at Jaipur Obsgenic Society. We welcome you, ma'am.
Thank you very much.
Thank you, ma'am.
Thank you.
Next, we have Dr. Rama Garg, ma'am, president at Ajmer Obsgenic Society. We welcome you, ma'am. Next, we have
Thank
Dr.
you.
Ruchika Bhajia Vargia, ma'am. Ma'am is secretary at Ajmer Obsgenic Society. We welcome you, ma'am. Next, we have Dr. Sangeeta Maheshwari, ma'am. Ma'am is secretary at Dehradun Obsgenic Society. We welcome you, ma'am. Next, we have Dr. Manpreet Kaur, ma'am. Ma'am is senior obstetric and gynecologist at Haridwar, Uttarakhand. We welcome you, ma'am. Next, we have Dr. Prakash Jain, sir. Sir is president at Udaipur Obsgenic Society. We welcome you, sir. Next, we have Dr. Patidar, sir. Sir is president at Kota Obsgenic Society. We welcome you, sir. Next, we have Dr. Abba Sapra, ma'am. Ma'am is president at Alvar Obsgenic Society. We welcome you, ma'am. Next, we have, now I request our chairperson to introduce our speaker, Dr. Sharmila View, ma'am.
Rama madam, would you be able to do the honors, please? Rama ma'am?
Yes, I can do.
Please, madam,
I
please.
can give the slide.
See, ma'am. CV slide is.
I'm very happy to welcome Madam Chamila, and she is President Trichy OBGY Society in 2026-28, Vice President Foxy 2024, Vice President Chair Osteoporosis Society of India, Secretary Justosis India Association, Secretary Academic Wing of Assisted Reproduction, Tanjore, MC member, PCO Society of India, Tamil Nadu IAMA representative for Simonic activities, organizer Yuva Foxy Trichy, Mesor. We welcome you, ma'am, for your kind words. Please start.
Thank you so much, Dr. Rama Garg, ma'am. That is an honor. And I would like to thank Monica for the opportunity of talking in front of Rajasthan and Uttarakhand societies. And it's a tremendous job, I would say, to bring in so many societies together, and you're doing it day in and day out. It's not an easy job at all. And such hard work, perseverance will get the right rewards, I would say, always. And such hard work, it should translate to work in Foxy also, because that will be of help for so many people, because updation and getting ourselves into the groove is always the one thing which obstetricians need to do always. And this topic of obstetric emergency is something which is very, very dear to my heart. And I would like to thank Monica for the opportunity. I'll just share my screen, and I'm so happy to see my friends, so many of them in this meeting. Sarveshri madam, she's always like, it's such a happy occasion to see madam always. Thank you for joining today. So the talk is going to be on amniotic fluid embolism. And we know that amniotic fluid embolism is a rare and potentially lethal problem. And I think Monica Gupta also touched on that. Like, it's not very common to have such complications, but when it happens, every obstetrician should be ready to manage it. The frequency may be very rare. It can be like 1.9 to 6.1 per 100,000 births, which translates to 1 per 15,000 to 1 per 50,000. But when it happens, the mortality rate may be as high as 60%. That's very, very high. And because of the rarity, most physicians and institutions have very limited experience with the management of amniotic fluid embolism. This was described in 1926. It has been explained as a diagnostic waste basket of unexplained peripartum deaths in the mother. It's quite an unpredictable event. Even at this point of time, we do not have any prophylactic intervention which will be effective at preventing it. So only if a patient does not become pregnant, it can be prevented. Otherwise, there's nothing to prevent this condition. There was one patient who was 34 years old. She was a Gravida 3 Para 2 Live 2 with previous 2 vaginal deliveries. Presented at 39 weeks of pregnancy with complaints of pain abdomen and leaking PV for 2 hours. Pregnancy had been uneventful up to that time with regular antenatal visits and all the investigations were within normal limits. On examination, there was no pallor, there was no edema. Systemic examination, nothing abnormal was detected. The blood pressure was 110/70. Per abdomen, it was a term pregnancy. There were moderate contractions. The vertex was fixed. The fetal heart sounds were at 136 per minute regular. PV examination revealed the cervix was 3 centimeters dilated, 80% effaced, membranes were absent, and there was a thin meconium stained liquor. She was put on oxytocin drip and antibiotics were given. 1 hour after admission, she suddenly developed generalized seizures followed by loss of consciousness. When you see a patient like this, you think about the 4 H's that the reversible causes which can be corrected, and that is maybe hypovolemia, which can be bleeding, obstetrics or otherwise, and sometimes it can be a concealed bleeding, or it may be related to hypovolemia, which is happening because of a dense spinal block, spinal anesthesia, which has become dense, a septic shock or a neurogenic block. Hypoxia can be a reason for the sudden cardiovascular collapse. That is, a pregnant woman who's becoming hypoxic very quickly can be because of a cardiac event like peripartum cardiomyopathy, myocardial infarction, aortic dissections, and large vessel aneurysms. Hypokalemia can happen, but hypo or hyper is quite unlikely in pregnant patients. But hyponatremia can happen because of increased oxytocin use. Hypothermia is not a common cause. The other 4 T's, which we call as thromboembolism, can be an amniotic fluid embolism, a pulmonary embolism, or air embolism, or a myocardial infarction. Toxicity can be a local anesthetic agent which is causing a reaction. Magnesium sulfate toxicity can cause a collapse of the mother. Or it can be tension pneumothorax following a trauma or a suicide attempts. Similarly, tamponade following trauma or suicide attempts can cause collapse of the mother. Or it can be eclampsia and preeclampsia, which will include intracranial hemorrhage. So all these conditions should go into your mind when you see a mother who's collapsing suddenly without an obvious reason. So this is how you work it up. Anything in the nervous system can be because of eclampsia or intracranial hemorrhage. Anaphylactic shock can affect the larynx and cause a edema, which can cause a collapse of the mother. Aortic dissections can be a reason. Hemorrhages, embolism, which can be pulmonary amniotic fluid embolism or hypoglycemia also. So this patient, once she collapsed, the pulse rate became very feeble. The blood pressure was not recordable. And then subsequently, she became deeply comatose and she was gasping. At once resuscitation was started, the patient was intubated and put on ventilator support. A second IV line was inserted. A bigger Venflon was put. IV fluids were pushed and blood was sent for investigations. Steroids were given. And the next 5 minutes, the patient developed a cardiorespiratory arrest. She was continued on artificial ventilation and simultaneously CPR was started. Why is CPR important? Because if you have a diagnosis of amniotic fluid embolism or any other reason and the patient's gone for a cardiac arrest, the immediate response should be cardiopulmonary resuscitation. Chest compression should be started with the heel of the hand placed in the lower half of the sternum, and you have to do a compression depth of 5 centimeters. When you compare CPR with a non-pregnant individual, there's no difference which exists in the technique to provide chest compression, and the rate should be 30:2. That is, you give 30 compressions with 2 ventilations provided with the use of a bag mask device. And suppose you've already put an airway in place, like an endotracheal tube or a supraglottic airway device, the clinician should now provide 100 to 200 compressions per minute and 1 ventilation per 10 seconds. That is equivalent to 6 breaths in a minute. This patient with CPR, the vitals improved gradually over a period of 1 hour. The pulse rate was now 120 per minute, still feeble. The blood pressure was 90/60, and the oxygen saturation was 98%. The probable diagnosis of amniotic fluid embolism was made for this patient. How does amniotic fluid embolism present? The patient can have chest pain, cough, dyspnea, cyanosis, bronchospasm, pulmonary edema or hypoxia, hypotension, cardiopulmonary arrest. Pulmonary edema and hypoxia happens invariably, and that is almost 93% of the patient will have. Hypotension is also a predominantary feature. All the patients will go for hypertension. Fetal distress is almost 100%. Atonic PPH is common. There will be a transient hypertensive episode sometimes in 11%. Headache can happen in 7%. seizures in 48%, coagulopathy will set in 83%. And the presentation usually will be in labor, 70% present in labor, 11% after vaginal delivery, and 19% during a cesarean. What is the pathophysiology of amniotic fluid embolism? When the embolism happens, amniotic fluid, fetal cells, or other fetal antigens have gained access to the maternal bloodstream. This exposure will trigger a systemic inflammatory response and is described as a cytokine storm. And that resembles an anaphylactoid reaction rather than something like an embolism going and obstructing. It's actually an anaphylaxis reaction. The maternal immune response, the system will respond to these fetal antigens, will release histamine, prostaglandins, and other inflammatory mediators. And that is the reason the cardiovascular and respiratory systems are affected so quickly. And the initial response from the cardiovascular system to the antigens will be a pulmonary vasoconstriction and a right ventricular failure. And what happens is there will be acute pulmonary hypertension and hypoxia. And once the right ventricular system has gone for dysfunction, the left ventricle follows with dysfunction, and the patient goes for hypotension and cardiogenic shock. Clinically, the patients will present with sudden dyspnea, cyanosis, tachycardia, and hypertension, and sometimes culminating in a cardiac arrest. The coagulation abnormalities will happen next after the hypoxia and hypotension, in the form of a DIC. Then that's because tissue factor and procoagulant substances from the breached vascular system of the placenta interface has entered into the circulation from the amniotic fluid, and this will activate the maternal coagulation cascade. This will lead to widespread microvascular thrombosis, and this thrombosis will cause consumption of clotting factors, and subsequently the patient starts bleeding, and that will come from the uterus because the placenta is separated, can happen from the surgical sites or the venipuncture sites. And this lethal combination of hemodynamic instability because of the right ventricular dysfunction with coagulopathy will contribute significantly to maternal morbidity and mortality. So the summary of events which happens in an amniotic fluid embolism is fetal antigens entering the mother's circulation will cause an immune-mediated anaphylactoid reaction. There will be an acute pulmonary and cardiovascular compromise, and that's because vasoconstriction happens because of the fetal antigens causing an immune reaction. There will be coagulopathy and DIC triggered by the procoagulant factors in the amniotic fluid. The systemic inflammatory response to the mother with cytokine release and mast cell activation will lead on to will cause so much of reaction, so much of cytokines being released. The mother is flooded with such antigens and she goes into shock. So there will be a rapid onset of hypoxia, hypotension, and coagulopathy. And that's why there needs to be an immediate recognition of critical care intervention to improve the survival. So this lethal triad of sudden hypoxia, sudden hypotension, followed in many cases by coagulopathy, all occurring in relation to labor and delivery, should point to a diagnosis of amniotic fluid embolism. But you have to diagnose amniotic fluid embolism only by a clinical method after ruling out other causes, because there's no investigation which will tell you whether definitely an embolus of fetal antigen has entered into the maternal circulation. And NICE guidelines has said, whenever you have a mother who has got a sudden cardiorespiratory collapse when she's laboring or she's just recently delivered, think of amniotic fluid embolism. And the investigations which need to be done, there's nothing like a specific diagnostic laboratory test to either confirm or refute the diagnosis of amniotic fluid embolism. At the present time, it still remains as a clinical diagnosis. And NICE guidelines has recommended the provision of immediate high-quality cardiopulmonary resuscitation, CPR, with standard basic cardiac life support and advanced cardiac life support protocols in patients who develop cardiac arrest associated with amniotic fluid embolism. And in this our patient, the fetal heart sounds subsequently were not heard. Uterine contractions had started. The patient actually had come in labor, so the contractions were continuing. The patient delivered a stillborn male vaginally after an hour. And following delivery, she developed severe atonic PPH, and she was started on erythrotonic agents to control the bleeding. The bleeding could not be controlled even after good uterine tone was achieved. The blood and blood products were transfused. Bleeding was controlled gradually. Vitals were stable. Output was adequate. The patient regained consciousness 5 to 6 hours after delivery, but she had residual motor aphasia, and then she was transferred to a higher center after 3 days in the obstetric unit. And that's why a multidisciplinary team, which includes anesthesia, respiratory therapy, critical care, and maternal fetal medicine specialists, should be involved in the ongoing care of women with amniotic fluid embolism. And this is how you manage. Suppose you have a mother who has collapsed. Immediately, you should start on high quality CPR, cardiac life support system protocol should be started. Immediately, you should notify the neonatologist, the maternal fetal medicine specialist and the obstetric care provider. Anesthesiologist who's specializing in critical care should be called. Intensive care specialist should be called and should consider immediate delivery. Suppose a pregnancy is viable, you can go for an operative general delivery like forceps or vacuum if it's already fully dilated, or should go for an emergency cesarean. And remember, the early phase of amniotic fluid embolism, it will be manifesting with right ventricular failure. And for that, you need to have an transthoracic echocardiography, which will tell you the right ventricular function. And always avoid excessive fluid resuscitation if the right ventricular failure is started. Instead, go for vasopressors like norepinephrine to maintain the blood pressure. And you can give inotropes with like dobutamine or milrinone to improve the pulmonary blood supply. And when you give these drugs, they will decrease the pulmonary afterload with inhaled nitric oxide or inhaled intravenous prostacyclin. So whatever you do, it should help in the pulmonary vascular dilatation. The secondary phase is once the right ventricle dysfunction starts, then the left ventricular failure happens, and the patient goes for a pulmonary edema. And here also the hemodynamics should be maintained not with fluids, but with norepinephrine and inotropes like dobutamine and milrinone. And always limit excessive fluid administration because it can overload the already failing heart. The coagulopathy which sets in may be immediate or delayed following the cardiovascular collapse. And that's why massive transfusion protocols should be activated as quick as possible. Aggressively manage uterine atony and search for pelvic lacerations or any other bleeding areas and stop the bleeding. According to NICE guidelines, when you have a patient with amniotic fluid embolism, you should deliver the baby as quick as possible if it's above the viable age. Adequate oxygenation and ventilation should be provided. And suppose the hemodynamic status says that there's an intravascular depletion, go for vasopressors and inotrope agents rather than excessive fluid to maintain the blood pressures, because excessive fluid will be actually damaging to the mother. Coagulopathy may follow the cardiovascular collapse. So that's why early assessment of coagulation status and early aggressive management should be initiated with standard massive transfusion protocols. And how will you do a perimortem cesarean section if the mother has collapsed and the baby is still alive and she's not responding to CPR, and the baby is over 20 weeks of gestation? You should commence CPR. And if she's not having any CPR, no response to CPR within 4 minutes of maternal collapse, you should not delay any other management. You should start the delivery of the baby. And you should not move the lady. You should do it in the place where she's collapsed and you started the resuscitation. Go for an incision which will give you the most rapid access, and that will be either a midline vertical incision or a suprapubic transverse incision. And that's why every resuscitation trolley in areas which are managing maternal care in the accident and emergency department, you should have a scalpel and umbilical cord clamps to deliver the baby when you are going for a perimortem cesarean section. And what is the outcome in amniotic fluid embolism? The maternal mortality rate is almost 20%, and 50% of the deaths will happen in the first hour if the mother has had a massive embolus in her pulmonary circulation. And when they survive, 80% can go on to have a neurological damage. And if the patient has gone for a cardiac arrest, very few will survive neurologically intact. And the neonatal outcome is also very poor. Only 60% survive, and the survivors, yes, 50% will have a neurological damage in event if the event has happened prior to delivery. So what are the phases in amniotic fluid embolism? In phase 1, as I said, there will be severe pulmonary or a systemic hypertension. There will be ventilation perfusion mismatch, there will be profound hypoxia, right heart failure. Then the left ventricle will dysfunction and she will go for acute pulmonary edema. In phase 2, both sides of the heart, the right as well as the left ventricle, if they have failed, there will be a global heart failure. There may be an acute lung injury and the mother can go for an ARDS and she can land up with coagulopathy. And that's why using this technology, that is transthoracic or transesophageal echocardiography, is very important for obstetrician. It will give you an easy access to the failing right ventricle. And suppose you identify that the right ventricle is failing, treatment should be tailored to improving the right ventricular performance with the use of inotropic agents and pulmonary vasodilators. And blood pressure support with vasopressors is preferred in amniotic fluid embolism over fluid infusion in the setting of a severe right ventricular compromise. And what will TTU tell you? This is the normal echocardiogram where the right ventricle will be actually smaller than the left ventricle. But in a patient who's having a amniotic fluid embolism with the right ventricular dysfunction, the right ventricle dilates and it will push the interventricular septum and the left ventricle becomes smaller. And what happens is the patient goes for more hypotension. And that's why putting fluid and dilating the right ventricle will cause more damage to the mother instead of giving vasopressors, which will be actually helpful in increasing the right ventricular function. And the patient is on ventilator, should avoid hypoxia as well as hypercarbia with acidemia. Because if there's hypercarbia with acidemia, the mother will go for more pulmonary vasoconstriction, and that will aggravate the already compromised function of the right ventricle. And regarding fluid balance, to give excessive fluids to maintain the blood pressure, the fluid overload will result in further right ventricular dilatation because the ventricle cannot empty because of the acute increase in pulmonary vascular resistance because of the amniotic fluid in the circulation, which is causing a vasoconstriction in the pulmonary vasculature. And when the right ventricle dilates, it's going to cause the left side displacement of the interventricular septum, and that will further compress the left ventricle, and that will cause a fall in the cardiac output. Vasopressors, which should be used, is norepinephrine at dose of 0.05 to 3.3 milligram per kilogram per minute. And simultaneously, inotropic support should be started to improve the right ventricular contraction, and that can be provided with either dobutamine and or milinorin, a potent selective inhibitor of phosphodiesterase. And these two agents will provide the additional benefit of dilatation of the pulmonary vasculature as well as a beneficial reduction in right ventricular afterload. And what about hemostatic resuscitation? You should now go for a massive transfusion protocol where you will give 1:1:1 ratio of packed RBCs, fresh frozen plasma, FFP, and platelets. And suppose the serum fibrinogen is less than 150, you can give cryoprecipitate to maintain the serum fibrinogen level. And what about the next? Suppose the patient needs a very prolonged cardiopulmonary resuscitation after an arrest, or she has gone for a severe ventricular dysfunction, which is refractory to medical management. You should consider ECMO, that is veno-arterial extracorporeal membrane oxygenation. And this is how the American College has proposed for the management of amniotic fluid embolism. So suppose there's a cardiovascular collapse, a cardiorespiratory collapse, start high quality CPR at once. And as I said, just compressions of 100 to 120 per minute, and you should avoid hyperventilation, as I said, to avoid hypoxia and hypercarbia. You should defibrillate if it's needed. She's gone for a tachycardia. Prepare for operated vaginal delivery if she's fully dilated, and an early perimortem cesarean delivery for more than 23 weeks. Early transthoracic echocardiography is very important after the return of spontaneous circulation. And you can do it during a CPR using the subsymphysoid view or during the short phases when you're going to check for the pulse, but never interrupt chest compressions just to do a transthoracic echocardiography. And suppose you've diagnosed acute cor pulmonale, start treatment of right ventricular failure with vasopressors, inotropes, and pulmonary vasodilators. Do not give fluid boluses. And if she's gone for coagulopathy already and she's significantly bleeding, early activation of massive transfusion protocol is fundamental. Use uterotonics and clinical criteria as indicated for the need of operative intervention to control bleeding. You can go for a uterine balloon tamponade or packing, prepare genital lacerations, or even laparotomy for hemostatic sutures or hysterectomy. And persistent hemodynamic instability in spite of the best medical management, or there's a need for a prolonged CPR, will now mandate the consideration of veno-arterial ECMO. So the take-home messages for this talk is amniotic fluid embolism is a potentially lethal condition. Our optimal early pericardial or cardiac arrest management has the potential to improve outcomes. You need to be familiar with the use of transthoracic echocardiogram in the labor and delivery units, and the use of massive transfusion protocols can be done, which can be guided by ROTEM and TEG, the viscoelastic test, which will give you the point of care interpretation of how much blood and products is needed for the patient. And both the use of these technology may improve the current dismal prognosis that is associated with amniotic fluid embolism. But more than that, you need to be prepared for such but serious events through education and team training, which may prove valuable in these efforts. I would like to invite all of you to this conclave which we are having on critical care in July 11th and 12th. And we are going to be particularly concentrating on point of care ultrasound, which any obstetrician can do in the labor room, where she can identify whether the fluid expansion is needed with an inferior vena cava ultrasound, can diagnose a pulmonary edema with lung ultrasound, and a cardiac ultrasound to identify any ventricular dysfunction, and probably can manage our patients much better. So you're all welcome to this conclave, which will be happening in July. I'd like to thank Monica and her team for an, as usual, excellent work which is done. Thank you so much.
Thank you so much, Charmila ma'am. And Sarveshwari ma'am, would you like to comment after the talk?
I'm seeing
I can see
Anupama
Anupama.
there. Hi, Anu.
Hi, Dr. Anupama.
Hello.
I assume you have listened to the talk, madam. Would you like to give some comments?
I
Charmila,
had
as
all
usual.
the talk, and Chamila, you are the best one because it's a revision of my subject. You totally taught me what I wanted to know. Thank you so much.
Love
Thank
you,
you, madam.
Sarveshwari. Love you, Sarveshwari.
That is Jayam,
Hi,
madam.
Jan.
Love you, Sarveshwari. The way you said is so nice, no? Okay. Because
Most
she's got
pleasant
another
person.
conference next month. She's too tight with her work.
Very good management.
Good.
I wish we could do it at time it was needed. Really.
A few words from Anupama, madam. Good evening, ma'am. Would you like to speak?
Anupama Futela.
Ma'am.
She's the one.
Yeah.
Who will
Thank
tell
you so
you.
much. Yeah, from all the Uttarakhand societies, a big thank you to Monica for having all of us here. You know, as usual, Monica, your program standards are high, and when we know that Charmila is there, you know, Charmila already knows that, you know, she is the charming lady. I have even named a few of my IVF girls with Charmila name. You know, when the girls say, इसका क्या नाम रखना है, मैं कहती मैंने चार्मिला को फोटो भी भेजी हुई है उन बच्चों की.
You've been
Charmila, I
friends
had a
for a
small
long time.
question.
Yes,
Yeah.
ma'am. Yes, ma'am.
I wanted to know that what is it which actually causes the amniotic? You had given a wonderful explanation about the pathophysiology. You know, I never really understood this much of pathophysiology of how the right heart and later on left heart goes on. But I was wondering that why it is so infrequent. Thank God it is very, very infrequent. But why is it so that amniotic fluid doesn't leak at every time, every delivery, in cesareans, normal delivery? So much of open channels are there, vascular channels. What really goes on which actually causes this amniotic fluid embolism and
Madam,
to leak in the mechanism?
that one main event which causes that breach, nobody knows. Because as you said, the placenta separates in most of in every delivery, the placenta separates. So why should a particular channel in a particular patient open up and causing? Because many times it's not hyperstimulation also. It's just a normal contraction. You cannot even say it's like she's hyperstimulating and it's causing a pressure and it's pushing the amniotic fluid into the maternal circulation. So that point, nobody is able to identify. I would say it's just luck at that point. There's no studies to say. But now, as we start having so much of literature on different types of obstetric emergencies, what we are understanding is there may be some autoimmune condition in such patients.
इसको बिल्कुल बाहर निकल के फिर वापस ज्वाइन करोगे तो हो सकता है.
देविका मैम, आप एक बार म्यूट कर लीजिए प्लीज.
So what happens is some patients seem to be more prone for certain problems. And we are not able to identify who is that because this lady is delivered twice vaginally with no incidents at all. And suddenly in the third delivery, she's developing such form of severe problems is something which is like cannot be understood. And we are finding it very difficult to explain ourselves when it happens. Recently, one of my friends also had that. And the main thing which was the problem in not saving the mother was not getting enough blood in time. They managed the ventilator part, they managed the CPR part, but the massive transfusion protocol which is needed to save her from the bleeding part, they could not bring her into that. So, and it usually happens in small centers where you don't have the facility for massive transfusion protocol. And the proper reason of why it happens is still not known, madam. I don't know the reason for that. Why some patients have that embolism entering.
Thank you so much. As it is, I personally just feel that it is equal to a very, very high mortality, and that is why it is so scary. And
nothing can be really done.
No, but Anu, but
All
what is
other-
happening is
other-
this use of transthoracic echocardiogram. Any obstetrician just puts a echo on the heart and sees that the right ventricle is failing. The dimensions, instead of giving fluid boluses, which we tend to do. Any anesthesiologist also does. We just keep on pushing fluid because we got the idea like PPH, like postpartum hemorrhage. She's bleeding, and that's why the problem is. But it's actually something else. So you identify the dysfunction, stop the fluid, and start them on vasopressors. And many anesthetists are now tuned to it. They do not keep on loading patients with fluid, and now also we have also got into that way of managing these type of collapses. Manage with drugs this whatever failure is happening, and when the right ventricle starts functioning, everything comes to normal. And that's why some patients are lucky enough to come out of, because the right ventricle has not gone for a dysfunction to an extent where we cannot retrieve her. So that part, if she's lucky enough, then we can take care of that. Otherwise, if it goes, it becomes like a cascade. Very difficult to bring her out of it once it starts. So we have to be aware of this transthoracic echocardiograph as well as the viscoelastic test. And now that's what we are keeping on telling, like 10 units, obstetric units having one TEG machine to tell you like how much of blood to be given, and managing, like any complication happens, everybody should come down to help, because everybody will be more objective rather than the person who's managing that condition. So they can say like, give this much blood, start this uterotonic now and all that. So that's why I think we should move ahead with a group practice rather than doing our own practice now, because the metabolic condition of the patient also becomes so different, and that's why it's very difficult to manage, and there's nothing like a low risk delivery now. Everything seems to be high risk now. So we have to change our way of practicing also.
Yes, I think that is the most important message, Charmila ma'am.
Yeah.
The way of practice and the scenario that we are living in. I just read about a mishap which happened in Udaipur yesterday, where a doctor was brutally assaulted. So, I mean, small setups, unless they are fully.
You try to manage and run away, that's all. Don't be in that place.
Yes,
Because
ma'am.
nobody is like this thing with you. Once something happens, you become the villain there, whatever you have done. So don't show you go away and get a. Now we are all encouraging our other members of the society to have a, like, suppose a mishap happens, don't meet it alone. Call everybody. When a group comes there and they try to explain, that mob violence usually doesn't start, and we should not give way for that at all. It is all bullying. Like, you have done the maximum you can, and if in spite of that it happens, you cannot be penalized for that with morbidity in yourself. No, that is very difficult to accept.
So, thank you so much, Charmila ma'am. And that was such an enlightening talk. You have got compliments from another chairperson, Indra Lamba madam. If she's there, she can unmute and give comments. And there's a disclaimer here. Kota OBGY Society, I had introduced the previous president and secretary. It has been taken over by Dr. Rashmi Pradeep Chopra as president of Kota, and Dr. Priyanka Maheshwari is the secretary of Kota. So welcome to both of you. I have sent you the faculty links if you wish to join. So after this, if there are no more questions, we can go to session 2. Jayam madam, our mentor and teacher of teachers, Guru, has joined. So madam, namaskar to you. And Viru,
Yes, ma'am.
start session 2, please.
Thank you, ma'am. It was wonderful talk. Now we are proceeding towards our second session, which is on the topic maternal mortality auditing. And for that, we have wonderful panels with us. First, we have as a chairperson, Dr. Rita Dhawan, ma'am. Ma'am is President, Dehradun Obstetric Society. We welcome you, ma'am. Next, we have Dr. Renu Sethia, ma'am. Ma'am is President, Hanumangarh Obstetric Society. We welcome you, ma'am. Next, we have Dr. Madhu Kiran, ma'am. Ma'am is President at Halwani Obstetric Society. We welcome you, ma'am. Next, we have Dr. Pavanpreet Kaur, ma'am. Ma'am is President at Rudrapur Obstetric Society. We welcome you, ma'am. Next, we have Dr. Seema Gupta, ma'am. Ma'am is President at Haridwar Obstetric Society. Welcome you, ma'am. Next, we have Dr. Pradeep Bandwal, sir. Sir is Secretary at Udaipur Obstetric Society. Welcome you, sir. Next, we have Dr. Preeti Arora, ma'am. Ma'am is Secretary at Roorkee Obstetric Society. Welcome you, ma'am. Hello. Next, we have Dr. Gunjan, ma'am. Ma'am is Secretary at Halwani Obstetric Society. Welcome you, ma'am. Next, we have Dr. Manpreet Kaur, ma'am is Senior Obstetric and Gynecologist at Haridwar, Uttarakhand. We welcome you, ma'am. Next, we have Dr. Sudesh Agarwal, ma'am. Ma'am is Senior Professor at Bikaner, Rajasthan. We welcome you, ma'am. Next, we have Dr. Tulika Pathak, ma'am. Ma'am is President at Kashipur Obstetric Society. We welcome you, ma'am. Now I request our chairperson to introduce our eminent speaker, Dr. Jay.
I think I will do the honors. To introduce Jem, madam, is like lighting a candle in front of the sun, but still I will make an attempt. So I know Jayam madam and I know her daughter Priya. If there are genetics, then madam, genetics really reflect in your family because these two are extraordinary ladies. So madam, I'm honored and thrilled to have you amongst us. Madam has been a gold medalist throughout. She has especially received the RCOG Distinguished Service Medal 2018, first Indian to receive it. And Dr. Priya has put this on Facebook. I have seen the pictures. Madam was the best committee awardee, heading the Foxy Adolescent Health Committee in 2013 to 15. Emeritus Professor, Tamil Nadu MGR Medical University, Managing Trustee of Garbh Rakshagi Group of Institutions, a very spiritual person, a Sai Baba Bhakt, Director of GFC Fertility Center, Trichy and Chennai, Vice President of Foxy 2018. She serves poor people, she feeds poor people, she works in mandirs, and madam, all your blessings are imparted and transmitted invisibly to everyone who comes in contact with you, whether physically or spiritually. We can feel it. We can feel that radiation coming to us, madam. Keep blessing us, Jayam, madam, and you can start your deliberation, madam.
Yes. So we are looking for the light in the darkness. Bless you all, whoever is there, because I know very well every one of you is going to be younger to me. By next year, I'll be finishing seeing full moons 1,000. So that is my caliber and criteria to talk about maternal deaths. Am I audible? Yeah. Yes. So with 56 years of practice, 56 years of obstetric practice going on, I still continue to practice. As Monica said, my daughter Priya Kannan, even though she is an embryologist by academics, I made her mainly embryologist to avoid obstetric catastrophes, but she loves obstetrics. And with Priya Kannappan, who is here, she manages my hospital at Chennai. Charmila is my adopted elder daughter, and next to her is Priya Kannappan. Yes, all of us know very well that couple of days ago, we have proudly found that Tamil Nadu stands second to Kerala just by 1 point. 24 is Kerala, 25 is Tamil Nadu. South Asia totally has had 67% reduction in the maternal mortality, and still the Indian data, all of you know well, it is around 88. Rajasthan is near to it. Uttarakhand is also not very bad, but reaching the triple figures data should come down. Right. We all know about all the causes, but of these causes, as Charmila spoke about embolism and anesthesia details, ectopics are emerging as a big, big problem. Of course, the precipitating factors are now more of anemia, as 55% of the Indian women are anemic, 70% of the pregnant women are anemic. Even a data in 2019-20 taken in the IAS circle of the Ministry of Health, Ministry of India, found out 54% of the IAS officers are anemic lady officers. Of course, we now have got a lot of details about medical disorders and cardiomyopathies also. But what I am going to talk about is what we are doing in what way we are involved, leaving alone the delayed decisions taken by the family, delayed transport, which is because of so many reasons in our country, and the third one is the delayed hospital care, for which every one of us hold our hand responsible, and delayed to take the responsibility to be accountable for maternal death. This is the fourth delay. The third and fourth delay are the one which make us very, very difficult to face the audit. So now you can see the three delays have come down so much. The fourth delay, refusing to take the responsibility, trying to shift the balance to somebody else, the imbalance to somebody else, we slip short and fail in our system and feel obstetrics is a very bad subject. The fourth delay has made a mother leaving her 3 children motherless. Look at this case and tell me, if your own sister is in that position, what will you do? Gravida 3, para 2, both deliveries were done by you, and the patient comes to you because you are a very lovely doctor and you are a doctor with a lot of good luck. And she comes. This doctor is now around 70 years. The entire family is with her. She comes in the morning, the nurse calls her. The 70-year-old doctor has heard about this, all these tablets for induction of labor. Because in the last century, before 2000, we were not knowing about induction of labor. Misoprostol, prostaglandins all came only after 1995. So this doctor has never attended any conference or anything, but somehow she knew about the misoprostol tablet, and she was keeping that 200 milligram tablet in her packet, and she broke it and put it in the vagina. How much? She is supposed to put 25, but we don't know how much she put. And by 9 o'clock, just 2.5 hours later, the nurse gives, every senior nurse, gives a frantic call. Madam, patient is bleeding with the head on the perineum. The doctor rushes. Along with the delivery, there is torrential bleeding. No case sheet written. No blood test report noted. Of course, the hospital is owned by another orthopedician. That orthopedician was very clever. He immediately arranged a vehicle ambulance. By the time the doctor shifted the patient to the theater and called the anesthetist. Anesthetist said, Madam, I cannot do this case here. Please shift, and he rushed away. He didn't wanted to be in the scene. Somehow, the patient was rushed to the medical college, died due to vertical uterine scar extending from uterine tear extending from cervix to convolute. Of course, heavy auditing was done. Considering her age, the audit officers left just with a remark. Why, madam, you want all these risk cases at your age? Please, madam, stop your obstetric practice. I think this sort of cases and these sort of comments we should avoid, because we should keep ourselves very clear of what we are doing, and whatever act of failure, or I won't call negligent, not knowing in detail about the procedures, we cannot make a patient suffer and make the children suffer. So in this case, I said to the doctor, accept I am the cause. I have used vaginal misoprostol in a good laboring woman unnecessarily. I did not accompany the distressed woman to the medical college. I need to face the reality. I need to be accountable. As Monica said, I'm very spiritual. And I said, for all this, if the patient's family gives you a curse, that curse will long last and will take your children to task. That is what I told this doctor. because this doctor was my own classmate. So I had the guts to tell the doctor, look, you have been my classmate, but you have used this unnecessarily. Because you should be very clear, understand your subject, make it updated. Otherwise, don't use updated procedures unnecessarily. So this fourth delay, every one of us will be facing in the audit, and it will be very, very difficult to answer this question. I will also give you some more days in this case. So in all these cases, we know well when the patient has got problem, 1/3 is only before labor. 2/3 is in labor and after labor. We now have got 98% of the patients delivering in the hospital. Why this postpartum deaths are more? Is it because we are having failure in our protocol or the patient is failing? We all touch your heart and tell me that it is the protocol failure, which we have not. When the patient comes in the labor, we work like a horse. In the second stage of labor and third stage, we roar like a lion and we work like a lion. After delivery, the nurse relaxes with a cup of coffee and we go to our house. 10 minutes after the delivery, we rush back to our house. So this tortoise work in the postpartum period of the persons involved in the obstetric care is the cause of postpartum deaths more within 6 hours of labor. Of course, all of us know well, all these things are all aggravating adolescence, para 4+, poor socio-economic status, public infrastructure being poor, lack of access, urban and rural area. All these things are all set for maternal death, for which we are not going to be asked for in the maternal audit. But poor birth spacing, you will be definitely questioned, because if you are the family doctor of the patient, they will ask you, why did you not give contraception? Have you written anywhere in your case sheet what you have this? And secondly, this sort of patients saying, I will come tomorrow, I accept. And next day the patient comes with a stillbirth, the doctor has been penalized, because you have been the family doctor. You should have cajoled her and see that she stays with you. And that should have been a videographed, that in spite of your half-an-hour lecture, the patient left you should have been videographed, and the doctor was penalized. And case went to court and the doctor was asked to pay 10 lakhs. So these sort of problems do occur, and we cannot say these are causes of maternal death and we can sleep over these causes. And that is where the EMOC, emergency obstetric care, which is being very much talked about world over, comes. The application of signal functions of EMOC is the duty of every obstetrician. Start antibiotics as needed, give uterotonics as applicable, max self liberally, assist the vaginal birth appropriately, remove the placenta manually then and there, and in early trimesters, do the curettage whenever it is required. Always know that you have to care the newborn. Document everything correctly and never fail to do a timely referral also. Now, yours is 87 and 99. Why is it Kerala and Tamil Nadu are 24 and 25? Yes, we have very, very early registration. Our NRHM JDC monk has said, the minute you see a urine test positive, do a scan immediately. Do not wait for 45 days. Don't ask the patient to come at 8 weeks. Do the scan immediately. 35 days, if you find a thin endometrium or endometrium which is still a 3-layered one, or it has not shown a good endometrial, they say secretory changes and residual endometrium, suspect ectopic. So that is where PICMI number has to be taken up even at the first visit itself. And trained birth assistants have been increased. Non-communicable diseases are being tackled in all medical colleges by the intensivist of a cardiology department, then and there with the patient, and a high rate of hospital deliveries. Of course, we have a very taskmaster NRHM. We had one by director by name Arun Tamburaj, with whose credit I will say we got our 25 MMR. We have good blood banks. That is what I am saying. It is not an ordinary blood bank which is there in the government hospital. If the private doctor calls and says, I have amniotic fluid embolism, I have a PPH in a normal vaginal birth, I need blood, the medical college has to supply the blood. They cannot say shift the patient. If the medical college refuses to give the blood, the director has given us his personal number. We can contact him and tell him so-and-so is refusing blood. To that extent, we have improved. Of course, antibiotics, government is also giving free. LSAS rate is little high, we have to accept. Sterilizations are being very much demanded. EMOX, emergency care is very easy. Safe abortions are also being refreshed every now and then. Now, to come to some of the few important killers in obstetrics, where we are caught with a preventable killer, is eclampsia kills both mother and baby. Now, look at a MD DGO, professor in a medical college. Why I have put this picture is, this is my place that is called Lord Sri Ranganatha is a Trichy. And this doctor is working at Pudukkottai, which is about 40 kilometers from Tiruchirappalli. And house, is about 25 kilometers down south from Pudukkottai, where she is working at Karaikudi. At Karaikudi, we have got MD DGOs. Pudukkottai has got a medical college with postgraduates. And this MD DGO doctor at 34 years, married 5 years, chooses to come to Tiruchirappalli for obstetric checkup and care. Is it not a transport delay in problems which is purposely done by the doctor? What happened to the doctor is, so the doctor totally is about 79 kilometers from her hospital at Trichy, from the doctor with whom she was treating. At 38 weeks, her blood pressure has been recorded 130/90 couple of times. And so she aramse starts at 8 a.m. from that place, and she has to have an appointment at 10 o'clock at this doctor. On the way, at about 10 to 15 kilometers, she becomes unconscious. She just has a driver by her side. Because the driver has been driving her every day to Pudukkottai hospital, the driver rushes to the hospital, Pudukkottai, because the driver knows she is working there and he has talked to some of the doctors. He calls some doctor in the Pudukkottai hospital, says, Madam is unconscious, I am bringing her. So the entire emergency department was at the gateway of the emergency unit. Her blood pressure recorded on admission was 240/150, and both mother and baby died. So the road to death was created by the unnecessary shift of herself to this person. And the other things, if supposing she has not been a doctor, if she has been only a patient coming from Karaikudi to Tiruchirappalli, what could have been done to prevent this patient is, should have been advised home monitoring. She should have been told about all the pre-monitoring, headache, vomiting, non-eating, disturbances in vision, mental confusion, epigastric, everything the patient should be monitoring every day and put a tick, yes or no. And any time after 38 weeks, any patient coming to the hospital should have a helper. The treating last leg of the hospital cannot have any reason for a death. And in all our cases in Tamil Nadu, for all the PIH cases, either we have our own nurse to follow up every alternate day with the patient, or give the details to the village health nurse in that area with whom her PICMI number has been registered, so that they follow the case. That is why we have mainly brought down the death of these cases. The next death which happens is, this I discussed even in ASUOG January, and Sharda Jain was surprised to see that patient can die due to massive hemoptysis to the pulmonary tuberculosis. But Kerala 2026 has brought this out as a very important cause of maternal death, and it is a preventable death, a detectable death in their report. We talk too much about obstetric catastrophes due to renal cortical necrosis, pulmonary edema, amniotic fluid embolism, and other things, but we fail to talk about tuberculosis. It is a city center hospital. That is, the hospital has got a Taluk headquarters hospital. And she is a gravida 3 at 34 weeks. When she gets a cough and cold, what she will do? She will go only to a nearby MBBS or MD. So the cough and cold with a slight fever of 99 was treated by her. And she went home. At 38 weeks, she comes to her obstetrician with whom she has delivered, with whom she had been a follow-up, and she found that she has 1 kg weight down from her 32 weeks. The doctor, of course, at that time, patient did not have any cough. So 1 kg weight down, the doctor or obstetrician also did not pay attention, did not disc. And she thought, because she is a gravida 3, she would have been poorly eating. Next day, she delivers and goes home. 10 days after the delivery, the patient gets again cough and cold. So she goes back to the physician for the cough and cold. Now X-ray taken, found to be pleural effusion, aspiration done. 3 weeks after that, since the cough and cold and chest pain has not stopped, she comes back to the obstetrician, and the obstetrician finds her in respiratory distress. And because she knows now she has got pleural effusion, she shifts her to the Medical College Trichy. AKT4 was started at the hospital, but still the patient died of massive hemoptysis due to pulmonary tuberculosis, which is again preventable. If only at 34 weeks, whatever has been done, and it has been followed up properly, we had about 4 weeks during their pregnancy and another 3 weeks after delivery, 7 weeks of treatment would have definitely avoided this hemoptysis. And in audit, it was a big, roaring one. Who is held responsible in this case? The general physician was left out. The final obstetrics treating medical college was also left out. The poor obstetrician, because she forgot on 38 weeks to ask why 1 kg reduction in weight, why she did not ask for the history of the cough and cold treated at 34 weeks, the doctor was held responsible. And at that time in 2024, we had some more cases which were also being harassed the doctors for saying that you have created the death. You have killed the patient. That is what the audit team also said. So all the Tamil Nadu obstetric gynecologists started roaring. But, you know, one person who roared very badly and said, we are not gullible persons. We are not simpletons. Who is that person? It is the previous speaker of your conference, Dr. Charmila. Every IMA, every obstetric society held a meeting condemning the act of the audit team and the doctor. And all this thing we insisted on saying that we are not simpletons. The way Charmila spoke was video recorded and it was flashed throughout Tamil Nadu. One day, Charmila became so much known both by government and private. The government Chief Minister of Tamil Nadu sent the DGP of Tamil Nadu to Tiruchirappalli, asking him to see that the doctors are pacified. The Director General of Police rushed down from Chennai to Tiruchirappalli, held all the meetings, many meetings were held, and we made it very clear that like government center getting the refresher course once in 2 months, give it to the private doctors. We need level 1 care support. Without that, don't do it. Please treat us in the dignified way. And this thing, we made it very clear. And after that, we started cooperating with the government. And 2025-26, the result is seen as MMR of Trichy, Tamil Nadu, which was 37, has come down to 25. It is thanks to the government coming down with this thing and the chief minister taking up interest on the videos which were getting broadcasted throughout Tamil Nadu. Even in outside the Tamil Nadu, many obstetricians have seen this thing. And that is why, that is one reason. When you have some problem, when you think that you are being ill-treated, never shut the door and do anything wrong. What has been done, I will tell you next. In your own place, it has happened. So the lesson learned from this thing is, another case, which I will give before I talk about the lessons, is unprotocoled, unguided guidelines, please avoid in obstetrics. This person is married for 5 years, has undergone an open myomectomy. This thing, fibroid mapping has not been done. Usually, whenever we do a fibroid surgery, we are supposed to make a mapping where all we have put the sutures. If you have put up a vertical suture in the fundus of the uterus, it is like a classical cesarean section, and that too a major classical cesarean which can always rupture. And it was an anterior wall fibroid which has been done. What the doctor does is, she plans for a cesarean section. During the cesarean section, this obstetrician finds out that the patient has got more fibroids, and along with the cesarean, she starts enucleating the fibroids also. Already she had a fibroid done and her uterus has been adherent. She was not able to pull up the uterus out. She was not able to exteriorize the uterus. And she removed 3 fibroids. But still 4 fibroids were there. She just pushed her uterus, closed it. 4th, 5th day, patient developed difficulty in breathing, wheezing, peritonitis, bowel obstruction. The worst part of it is enema was given for her not passing flatus. As any of us are doing this, then the patient was shifted to the highest center in Tamil Nadu, that is Ma Kaveri. Patient had found to be having 2 tears in the bowel, and she died later. The hospital of the obstetrician was closed, and it is still on action because this happened just in November 2025. In this case, what all the things? Have we got any guidelines by ACOG, this thing, FIGO, RCOG, or anything? Obstetric, this thing, Australian guidelines, NRHM guidelines, and NICE guidelines on myoma surgery during cesarean section? We do not have. So when we do not have anything like this, we have no business to do this procedure. And all the more giving enema post-operatively. So with all these things, with these 2 cases, the second case, only the doctor was closed and the auction is on because the public made a big hue and cry. That big, this thing, hospital was massively raided by the public. They could not also control it. So what has happened is, in 25-26, the audit is done in Tamil Nadu by the health department with 2 senior obstetricians who are retired, who know how to do the audit. Because we can do audit in many ways. Monthly video meeting with the audit team is done by the respective centers with whom they had the problem. They do not make a big marriage reception like calling everybody together, whereas they individualize now. Death audit team is now inclusive of private obstetricians as IMA representatives. Public are avoided so that the doctor is not looked down upon. That is how the audit is going on in Tamil Nadu. Now, I have another case in which very gently this question was put to the obstetrician. And you all will understand, is it correct also? Avoidable cause, gently questioned by the obstetric team by the audit team in January 2026. This patient is 28 weeks, autoimmune hepatitis, diagnosed at Trichy. She goes because her mother is somewhere at near Pondicherry. She goes to Jipmer for treatment. Jipmer, with all its academic output, was able to manage this patient up to 30 weeks and stabilize the patient and send the patient back home. She delivers her home 34 weeks. And after delivery, the hepatitis returned back. She was suggested a liver transplant. She goes to a liver transplant center. Finally, does not get a liver and she dies. The question by the audit team, the obstetrician of the audit team asked the doctor very gently, why did you not suggest termination at 20 weeks? I consider this not as an accusation, but as a future lesson which is to be learned by this. Because nowadays, we know well that acute fatty liver or anything can be due to thrombocytic microangiopathies, may not be a preventable death, may be due to so many autoimmune disorders, may be managed, but these sort of cases are not the bread and butter of the obstetrician. Once they are transferred to an institution, I would prefer these doctors not to deliver these sort of cases. And when the doctor has seen it at 20 weeks, definitely we have medical therapeutic terminations which are acceptable. And at 20 weeks, having seen this thing, fatty liver and serum bilirubin to be 22, I think we should have allowed this patient to consider termination instead of asking this patient to go for treatment at Jipmer. So this I consider as audit as a lesson, not a blame game. So acute fatty liver, leave alone these cases, now come to the cases. Every month, there is a hospital which is doing its own audit, and the audit results are shown every monthly. We all know PIH, preeclampsia remains the same dark blue. PPH is there. And you also see equal to PPH is another blue line, which is infection. Of course, malaria is also now erupting as another cause. In Indian scenario, malaria is being looked at as a cause of fever in any patient which is not otherwise proved. So we have to keep this also in account. So coming to this PPH, which is being talked as such a red line, we see the blood. We are so scared. Uncontracted uterus. Now, this is the case in your own area, Rajasthan. Archana Sharma, 42 years, when she had a case and it went to court, you always commonly knows 302 booking. That means you are a murderer. 302 booking was done and this doctor shut herself inside a room and died by suicide. I am not aware of what is the follow-up of that case, but it is a pregnant patient following postpartum hemorrhage. Tamil Nadu, are we not seeing those cases? Even last month, we have seen 2 cases in 2 big centers, showing thereby that postpartum hemorrhage is a bullet even in a normal delivery. It is in a big private center, tertiary care. Another one is in a municipal corporation area. But the big private center and the municipal area also need to learn lessons from these cases. I will tell you what the lessons are. The first case is the big private center case is IVF conception at 35 years. What do we call it as? Elderly primigravida. And they are say because they want to show their skill, induced labor. Delivered after 20 hours, severe PPH, laparotomy done, no trauma was found, subsequently died due to DIC. Atonic PPH itself nowadays, for all your information, is considered as an early manifestation of DIC. Please note that if the patient starts bleeding with a vaginal delivery, with the previous normal deliveries or within 18 hours of labor, that means she is going to have DIC. Because Professor Arul Kumaran and other people are working on it and they are coming out with a fibrinogen support also. And this case is being looked up for other details. And I am saying this could have been prevented and this should be taken up as a lesson because 35 years a patient We would not like induction of labor, let her go on her own for delivery. The case 2 is in a municipal corporation. What is this thing is, the doctor who has operated on this patient who has been a professor in the medical college, and she retired. She has given resignation and started her own nursing home. And she does a LSCS. 4 hours later, shock index is 1.1. I'm not going into details for lack of time. Shock index is 1.1. Hypovolic shock requires massive transfusion protocol and massive blood transfusion protocol. Nothing is available in the municipal corporation. Reopened the abdomen in her place because her husband is a surgeon. Continued in shock. She refers after 24 hours to the medical college, and there she died of multi-organ failure. What is the lesson to be learned in this case is shock index 1.1. I would not prefer to reopen in this municipal center without massive transfusion protocol available. I would have taken the patient to the medical college on the same day, 4 hours after surgery, instead of sending her after 24 hours. This is the 4th delay for which we become accountable. In Tamil Nadu, what has happened is we have started this public-private partnership with the government without no blame game. We don't allow the government to blame us, and we private doctors also do not accuse ourselves. So hand over the key carefully and safely and get the results in a better way. And this second case, which has been done, another case is one where it is a high-risk case. Patient has been 5 grams hemoglobin at 26 weeks. She had 4 units of blood transfusion, and she gets induced in a private center. 6 hours after delivery of cesarean, hemoperitoneum, sutured, oliguria, everything, coagulation. And this case has been put by J.D. Seamonk in our MMR group, and she has asked us to discuss. This is the way by which the audit system should be taken as a cooperative method instead of writing it as a document, and get ourselves better improved with our MMR. Outcome of the audit in all these cases is, all juniors, please note that many seniors are available for help. Seniors also shouldn't hesitate for fear of legal tangle. If you go and attend a PPH case, you are not going to be blamed for the PPH case. I have attended so many cases. Instead of worrying about ourselves, let us worry about the patients. Let us less worry about ourselves as we are going up and aging. So death audit is identifying maternal death, putting together a maternal death file, developing a case clinical summary, organizing a maternal death response session, and get a results only. Conducting the maternal death response session, we have got 6 steps. That is, out of you, make somebody chair the session. Re-evaluate all the results of the patients. Let the doctor present it as a clinical summary. Let the team sit and review the case and find out what is the recommendations, what are the failures, and future action plan, and develop a MDR session report. This is what the WHO guides. Plan for the next session if there is another case also. This is not only WHO, we also have our NHM. Chapter 62 of the National Health Program relates to obstetrics, where it has talked about all these Lakshya, Dakshata, Digalkari, Anmal, ANMs, and newer guidelines also. All obstetricians should go through these things so that they know how to conduct deliveries safely and get our MMR reduced and keep ourselves well away from the audit system. Now coming to the Kerala pattern, which was started in 2004, 20 years, it is what is called a confidential maternal inquiry. What it has done is, Professor Paley, by Gnanasekharan, Dr. P.K. Sekharan, and Raja Krishnamurthy or somebody, all the 3 with Sridevi and others, have met the government, and the government has supported it, and they are following the European pattern of confidential maternal they say. So they write case sheet number 101. They don't write the name of the patient or the doctor. No blame, no name, and auditors are not dissing or they're not getting any money, and auditors are daily meeting themselves on Zoom and get further details and support the patients in near miss cases also. The key interventions and impacts of this are in the Kerala are very good protocols and training, obstetric rapid response team formation in every area, and addressing non-medical causes also. There you find there's, as in Tamil Nadu, they also have 70% death deliveries in the private. You see, they have found out very interestingly non-medical conditions like Moya disease. I don't know what is Moya. I'll have to find out. Then intracranial space-occupying lesions, bacterial meningoencephalitis, and massive hemoptysis due to pulmonary tuberculosis. In 2025-26 audit report, they have detected cases of these things, which are all cases for future guidelines, so that we have to be very clear about every. In 2022, they said suicidal tendencies were more common in Kerala. At that time, it was corona, and they said they were causing death. This year, they have put hemoptysis due to pulmonary tuberculosis. So the causes of death and the auditing pattern need not be the same. It differs case to case based on what are the findings that can. So that means they say death audit protocols, which WHO says, we have both the roses as well as thorns. The thorns should be digested, the roses should be allowed to blossom, so that no woman loses her life. Every death be accounted. Maternal death should not be limited to the number only, and it should not have any legal implications. No name, no blame. No one to be punished for this unless it has been a very heavy, bad damage, like giving an enema in a paralytic ileus patient. And every death, kindly know that it teaches a lesson. I remember all the deaths that have occurred in my hospital, delivery of about 42,000 cases, which I have attended, both in my hospital as well as in government hospitals. And I remember every death which has happened. There are about 8 to 10 deaths I have witnessed, and I got. When you go for an audit, you are called for an audit. When you go there, what you should do? Arrive, go there at proper time. Don't go 10 minutes late and get this. I saw a patient and came. They get annoyed. Participate actively with discussions. Respect everyone's way of expression. Do not give them this thing about saying that, no, like that, don't answer. Accept discussions and disagreement without resorting to any verbal abuse. Respect confidentiality of the discussion. And if you are in a group, don't go and talk about that case to outside also. Agree not to hide useful information. Do not give false information. Try as much as possible, though it is not easy, to accept that your own actions can be questioned. Please understand these things. So, the maternal audit is not to accuse you, not to give you any punishment. It is to trace the black box of an aircraft disaster. The black box finding out is the audit. It can be, as it is done in Tamil Nadu, verbal audit, or it is a confidential maternal death inquiry, as it is done in Kerala, or in West, they also have records and date. There is another thing called near miss audit. Near miss audit is also very, very important for us. So, is audit is enough? Audit alone is not enough. We have to take remedial actions like what has been done in Kerala, like giving training, what has been done in Tamil Nadu, as giving them more refresher courses and work out the solutions also. So, we were 536 per lakh MMR in 1992. Now, we are about 87 or 88, something like that. We have, see, the wide area which was there available has been narrowed down by all our activities so that the patient cannot go into the various areas at the false case. It has to come this way only. It cannot go like that. So we have narrowed down very nicely, and we are making this go a success. Near miss cases, every case teaches you a lesson. I missed the case. I somehow managed. It is not the credit. You learn a lesson and discuss it with others so that others also learn from you better. As obstetricians and gynecologists, be courageous, prefer group practices, maintain good record. 147 consent forms are available with Foxy. IM also gives you very good case sheets maintenance. Please spend money on data operator. Get refreshed every 2 to 3 years as it is done in the West. Otherwise, in the West, they make consultant go as general practitioners. You cannot deliver a case. Be a member of good insurance system. Face the audit with all records and courage. Two sides of the coin are always there. You may be accepted, you may be denied, and you may learn a lesson also. Be there, and seniors like me and Saresh Natyal, and I saw somebody else also, are all available for your support. Be there. I wish Monica the greatest success in all her work as throughout in her life. Thank you very much for your patient hearing, and let us wait to catch this moon. We have yet to reach land in the moon. I hope we will catch it up soon. So I stop sharing this.
Thank you so much, madam. We are mesmerized. This was a lecture
Oh,
beyond.
Charmila is there, huh? The roaring line, you know what she said? That collector boy said like this. In Tamil, exactly. She put the word in Tamil. And the collector payya.
Collector pasanga, madam.
Collector pasanga. She said collector boy. You know?
What happened, Charmila ma'am? Like you were like in
Charmila
the
will tell about that video.
We
Please put the
we
word.
had a
They also have
problem
to know how
like
to face the audit, and they have to get the courage.
whenever we used to have maternal mortality audits or near miss audits, they used to always be very abusive to private obstetricians. Like they will shout and say, "You didn't do this, you didn't do that," and many senior members used to cry. Because many times we would have done what could have been done at that level, but if it happens beyond our control and something goes wrong, they will not even accept an explanation, even if they try to talk. So everybody will gang up on the obstetrician, and sometimes they used to have the patient's relatives also there when the audit is happening, and the relatives also will scream at the obstetricians. So many like very senior obstetricians have started leaving the practice. So we had a protest meeting in all the societies and all IMA branches of Tamil Nadu in a single day. That time in Trichy, because I was vice president of Foxy at that time, I gave a talk to the press on that day regarding, and that time I mentioned the collectors as small boys, like compared to our experience in
You did not give a
reproductive
separate.
medicine.
No, Charmila, it was IMA meeting. The president of Trichy Society was sitting there. IMA president called Charmila as a Foxy vice president on the chair. She went and joined those 5 people. All the press were doing the video recording. The minute she went there on the days, she became so powerful. She blasted the collector, and it was press recorded 20 minutes of her blasting. At one point, I had to send somebody from the floor to quieten her.
No, he was like telling that, we are 70, 80 years old obstetricians, and the collectors are 30, 35 years, small, youngsters, and they start abusing. So that was clearly, and, like the seniors have been abused by the youngsters, just like that, they don't even give a chair to sit down, and they make you stand as if you are a prisoner or something like accused or something. And madam was very clear in that. And after that, the way the audit and the respect which the doctors are getting in collectors meeting have changed in Tamil Nadu. So all thanks.
We also have to raise 2 occasions. Join together, all together. Put it yourself in Rajasthan or Uttarakhand. Definitely the government will yield now.
So now we are having a very good partnership with NHM Tamil Nadu, and all the audit meetings, we have got 2 obstetricians sitting as nodal officers in each district meeting. So the collector will ask the opinion of the private obstetrician also in any audit. So that way, when the blame game comes down, everybody has started changing, and that's why our MMR has fallen down from, actually we were 56 3 years back. Now we are 25, nearer to Kerala, which is 24. So we have come second in the country now, and
But
that
you
is
know,
because we have got
Kerala
a
has
good
got-
relationship with NHM Tamil Nadu.
Kerala has got 2.75 lakhs delivery. Tamil Nadu does 8.7 lakhs delivery. As the number of deliveries go up, the number of deaths are also supposed to. We have got more remote places in Tamil Nadu, inaccessible places also. But still, yeah. Next year we may even come number 1 if we continue the same energy.
So the target for NHM Tamil Nadu is now single digit. We want to come down below 10. That's what is the plan, this thing. And in our critical care conclave, we have got the NHM officials coming down to have a partnership meeting with the private providers. So that will happen on Friday evening. So Monica, you're welcome for that also.
To interfere here, but Sharmila, I wanted to say one thing. When there are audit reports, something like what Dr. Jayam has just said, that elderly primary, why have you induced 35 years? It is not something that bad at 35 years if induction has been done. The course of events have been very sad, but something like this, if
no, for that particular patient, Anu, they had given 5 times misoprostol. Elderly, and she's been operated for endometriotic, deep endometriosis. She was operated on. IVF pregnancy she was, and they'd given her misoprostol 5 times.
Okay, so that 5 times.
20 hours, 5 times.
20 hours she was in labor, and she developed atonic PPH. It was not a traumatic PPH, and they could not control the bleeding. And we know that endometriosis will cause placental issues. So we don't know how deep the placenta was in that patient. So that is the reason why that came for an audit in a big way.
I personally feel that the ma'am has given that different form of Kerala audit. I feel that, that is a better way of auditing rather than, I just couldn't gulp this.
Kerala is better way. But
here also we are almost following that only, what we do is, NHM is very soft now. So we have a very, we try to understand where it went wrong, and we say the corrective measures also. So nobody is allowed to blame. So it is like, this is the way it was done. It could have been done better. And what could have been the main problem in many of our maternal deaths is the referral. That is, they refer from one place to the other, which they have said very clearly. When you have identified a patient as high risk, put your birth plan in place. The moment a complication happens, she should go only to this particular hospital. She cannot be shifted from one friend's hospital to the other. So that referral has helped in a big way, because suppose somebody develops an embolism. So it's not like you don't refer to your friend's hospital, it's nearby. She goes to the most important, the very well-equipped tertiary care, where she'll get the best care. So that referral has helped us to reduce the maternal mortality.
So was it the government officials who took the initiative, or it was the daring Sharmila who
No, it's all Jayam madam. Jayam madam has been working for a long time in that. She knows.
I am there in the maternal mortality for the past 20 years.
She's been there.
I have gone to 65 places in 2012 in India, helping mothers survive, HMS program.
So, ma'am, you collaborated it with some government officials, NHM
No, see, after this protest meeting, NHM is calling us for the audits also. So now we understand where our lacuna is there, and we try to correct ourselves, and we give that to the person who has got affected, and she's not blamed. So she doesn't get that guilt, and that way we keep her see, when you lose your morale because of this, somebody needs to support you. So that support we give. NHM is also not very harsh now. They also tell them like what was the lacuna, and we correct ourselves. So what happens the next time it doesn't happen, and automatically the problems they will get solved in the best way possible. So that we give that timeline, like this happens, go here. If it happens, go here. Like that, the private practitioner also will help her as well as the NHM. So that way things are improving. It's both.
We are almost near Kerala, except in Kerala, there are only private obstetrician go for confidential inquiry. In Tamil Nadu, the government also sends its team first and then ask us to go next. So probably soon we will overstep them and go first.
So if suppose a death happens in Trichy, I am the nodal officer for Trichy, I'll be given the case history first.
So I go for the audit. So there we threadbare discuss, and there's no blame assigned to anybody. It is just the sequence of events is broken down by the private person as well as the government hospital, the person there. So we clearly say this is what has happened, and if we can change
I
ourselves.
will tell about that MTP embolism. They say they teach it as hypoxia ischemic encephalopathy. For Friends Hospital, both of
That
us
is
went.
one patient was
Near miss.
undergoing a tubectomy. So they'd given her spinal anesthesia, and the moment pneumoperitoneum was created, she went for hypoxia. So they intubated, ventilated her, and they shifted her from a remote place near Trichy to Trichy. So myself and Jayam madam went to see the patient, and then we told them like this may not be the best care, and she was shifted to another place, the best place, and there she was there for 25 days and recovered. We were constantly in touch with the obstetrician and the tertiary care physician. So that way we made it smooth for them, and the patient recovered at the end of it. It was hypoxic ischemic encephalopathy, but she recovered from that because the best care was given at the correct time.
The score was 2/15.
The Glasgow scale was only 2 when we saw her.
I really salute you guys. I really salute, and it's lots of learning here. Monica, really, I mean, इतना अच्छा तुमने ये program किया ना.
I have not done anything actually. I just met Jayam madam and Charmila ma'am and Priya at Indore. So we got this together.
The
It just
only
happened.
thing I want to say that both are full of knowledge of everything, starting from medical legal, starting from labor up to medical legal.
You will
So
soon get the thing. PPH only PPH, you will get the
Anupama,
part.
your question
Soon
was
you will be
better.
using fibrinogen precipitate.
I had a question,
Transmissions of
madam.
low risk pregnancy. PPH will be becoming atonic PPH also will become a preventable one. Soon you will get the
Anupama, you can say
research
about
is
the
going on.
PPH in Pahad, in
Hello.
hill area.
Hello. Dr. Anupma, can you hear me?
Yeah.
Dr. Anupma.
Who is that? Madhu Kiran?
Yes, ma'am.
Please.
I'm speaking from Uttarakhand. I just wanted to know from our own Uttarakhand Society President, Dr. Anupma, do we have such audit teams here also, as far as I'm aware?
Yes.
No.
यार मैंने कितने डीजी हेल्थ के साथ बात करी हुई है, और अभी तो मैं उनकी ट्रेनिंग एनएमसी अभी तो मैं उसी पे ही हूँ कि ट्रेनिंग मॉड्यूल्स हम लोग शुरू करें, हम लोग रेफरल प्रॉपर बनाए. हमारी गवर्नमेंट का अलग ही प्रॉब्लम है मैम. हमारे यहाँ पर तो अभी तक ब्लड बैंक्स अच्छे नहीं हैं, हमें अभी तक जो है रेफरल एम्बुलेंसेस प्रॉपर नहीं हुई हैं. खैर मैं रोना नहीं रोना चाहती हूँ, आई मीन लॉट्स ऑफ थिंग्स टू बी डन, बट द थिंग इज कि what I have learned is conversation and team building is very, very important.
Very, very important.
And we should continue.
That is very important.
See, after we talk to NHM Tamil Nadu, even private practitioners can get a massive transfusion protocol pack when we want from the government hospital.
That is great.
Suppose you've got an emergency in your private hospital, you can get a pack from the government hospital. Similarly, suppose you want an ambulance, even private patients can be shifted by ambulance from your place to the government college.
Yes.
And government college has got a beautiful setup of managing the high-risk pregnancies, all the complications. So the results are very good. So I don't refer to any corporate. I shift the patient to government hospital and I go with the patient.
Wonderful.
And they manage so well in a government hospital.
Only thing is we should have the courage to go with the patient.
You should not feel
The first
bad for
case,
something.
my own classmate was, I said, I scolded her because you should have accompanied the patient. When you have not written a case sheet, when you did not have time to write the case sheet, you should have gone with the patient.
I really
Tell them, I did not have time to write.
Ma'am, can I add on? I'm Dr. Archana Mishra from Madhya Pradesh. I'm Senior Joint Director looking after maternal health.
Welcome, madam. Give us all the details of your increase in the maternal mortality.
Yes, ma'am. It's not increased, but we are from you are first. You are second from the top, and we are second from the bottom.
Second from the top, bottom.
We have. But I think it's not amusing thing for us because ours is a large state and we have nearly 15 lakh deliveries per year.
Extra. UP has got extra.
Madam, they are from Madhya Pradesh, madam. She's talking.
I understand.
Yes, I am from Madhya Pradesh. I'm myself as an obstetrician looking after maternal health, and Tamil Nadu has always been a source of inspiration to us. because we have been learning a lot of things from Tamil
Kerala
Nadu.
also.
But Kerala is there, but Tamil Nadu is more friendly with Madhya Pradesh, and we have been there also. I just wanted to highlight some things about Madhya Pradesh. We have approximately 1600 deaths per year, and getting every death audited is a challenge for us. And 76% of the deaths are happening in facility, about 18% are in transit, 8% are at home. And we have 10 medical colleges. So auditing every death at state level becomes difficult. So we have taken support from Foxy members, but each month nearly about 150 women are dying. So auditing every death at state level, looking at the protocols, teaching them is for the Foxy members of the private sector, it becomes difficult for them also. We tried to engage some of the Foxy members, executive members, but they are not able to take out the time.
Please
So,
include us from Tamil Nadu. We will do it.
yeah,
Madam.
that would be great, madam. That is why
Yeah.
first of all I thank Monica because she has
Sharmila
taken a
is going
very
to learn
important topic.
Hindi.
Because every time government has to answer this thing. We have 90% institutional delivery. Out of these, 80% are in government institution. 12 lakh women are delivering in government institution. In the private sector, only 1.5 lakhs are going.
How many deliveries per annum in Madhya Pradesh? Tamil Nadu is 8.6 lakhs.
14.9 lakhs, madam.
Okay, so you are nearly double of ours.
And we have 40% of the population is tribal. We have remote districts. So
yes.
And it's a large state if you see the geography wise also. So we really need support from
yes, Archana,
people like you,
Sharmila is
madam.
learning Hindi, so she will be able to talk to the nurses.
Sure, madam.
I will talk to the doctors. Priya Kannapan also is my junior.
And you can inspire our Foxy members also who are
yes.
working in private sector to
with
come
the
and
doctors. We will not bombard the doctors.
To join us in maternal death review.
Please suggest our names to your society.
Sure, madam.
We'll send you our CV if you want.
Sure, ma'am. Sure, ma'am.
We are willing to do it.
You should identify right
programs.
persons. Actually, Dr. Archana, I feel in your locally, it is not necessary that any executive member would be the best member. It is more of a willing member.
I know, madam. But our Foxy members are very busy in the they're not able to spend time. We have tried, madam. We have shared the case sheets. We have shared the case sheets also in advance. 1 month advance that you just examine 2 case sheets because we have 150 deaths per month and we take only 20 deaths. So myself at the head office, I am the only obstetrician.
Archana,
and I have to do other
initially you send
administrative
your
work
case
also.
sheets by WhatsApp to us.
Sure.
I used to get all the case sheets from the IAS officers and they all used to ask me about 30 years ago, Madam, what should I do? Health secretary. I used to give, don't worry, it's avoidable, unavoidable. First thing is avoidable or unavoidable. If it is avoidable, you go in for further auditing. Unavoidable cases, leave it out. If they deliver at home, it is not our problem. If they take 3 days because husband is out of station, that is not our problem. Then coming into the hospital, first look into the intrapartum and immediate postpartum. That if you are able to take it, avoidable deaths, please audit. Unavoidable, just leave it to the society. Okay, that you will bring down your auditing need to about 100 or 150 per month to just 40 to 50 per month.
Yes, and the major cause is coming out to be hypertensive disorders of pregnancy and severe anemia.
Yeah, these two things we can definitely make it better. Please.
Yes, ma'am. We will learn from
Sharmila, she will also speak in Hindi because from today she is going for Hindi classes.
Yes. So I'm very hopeful that Monica is there, and so she's always there to help us. But
okay, sure, we will do it. We'll do it, Amma.
Sure. Thank you, ma'am. Thank you so much.
Thank
It was a very
Bless you all.
nice
Bless you all.
lecture. Thank you, ma'am. Thank you.
Thank you. Thank you for the knowledge.
And Charmila ma'am is going for presidential election. So I think she will bring a lot of changes when she becomes president of Foxy.
चार्मिला
2027 she is going for election.
आगे लग नहीं सकता चार्मिला तुम्हारे अलावा, तुम आगे
नहीं, Shamila, 26. You are going.
20, no, next year.
27.
Next year. 27.
Okay.
27. Thank you. ma'am.
Anupama hai to?
Wish madam all the best. And Ajit madam, thank you so much for joining. And he is one person who is very dedicated to this cause.
Really.
And I think if we align with Tamil Nadu's model and people and the responsible people, I think we can make a difference, Archana ma'am.
For sure, Monica. I'm very hopeful and confident looking at the enthusiasm of the entire team that
Sure.
we are of the same nation and we have to bring India to that level to achieve SDG. And Tamil Nadu and Kerala, Tamil Nadu and Maharashtra,
Yes.
they are always been a source of inspiration. But Madhya Pradesh, we have to look very like it's a black blot on our forehead, actually, we should say.
No, it's
Every time.
Yeah, we're struggling with some other issues. I think once those issues are solved, we can achieve this target. And
There are HR issues. We do not have specialists. We have less number of medical colleges. But when the report card comes, everybody sees the data, what is there. Nobody sees what was the background of this thing.
True. So thank you to all dignitaries for participating actively in this. I should call Jaya Madam, it is like an oration for us. Such an extensive discussion on maternal mortality with Charmila ma'am there, who is so important in bringing Tamil Nadu to the forefront. And of course, enthusiastic participation by all faculties. Thank you so much. And today is a very special day. We are talking from Tamil Nadu, from Uttarakhand, from Rajasthan, from Madhya Pradesh. Every possible state we are pitching in with our problems. So now to make the things a little lighter, Priya Kanappan is there. So after the heavy issues, we'll go to a slightly lighter issue, though that is also very ominous. But venous thromboembolism, what we can do about it. So Dr. Virul, can you please start the panel discussion?
I'll share my screen, ma'am, if that's okay.
Yeah, sure, Priya.
We are now at the last part of our
Actually, I'm not able to share. Can
No,
somebody
Dr.
make me as co-host if that's okay?
Dr. Priya, we'll just take the names of the panelists and then we'll give the screen share.
Yes.
Virul, please start.
Okay, ma'am. So we are at the last part of our Synergy 31, which is panel discussion on the topic venous thromboembolism. For that, we have moderator Dr. Priya Kanappa, ma'am. Ma'am is coordinator South Zone Foxy Quiz Committee. We welcome you, ma'am. Next, we have series of panelists with us. First, we have Dr. Arun K. Dora, sir. Sir is Professor AIIMS Bhopal. We welcome you, sir. Next, we have Charu Johri, ma'am. Ma'am is at consultant at Indira IVF Alwar. We welcome you, ma'am. Next, we have Dr. Divani, ma'am. Ma'am is associate professor and my immediate sister. We welcome you, ma'am. And next, we have Dr. Kirti Patel, ma'am. Ma'am is associate professor at NSCBB Jabalpur. We welcome you, ma'am. Next, we have Dr. Namrata Bansal, ma'am. Ma'am is secretary at Hanumangarh Obstetric Society. We welcome you, ma'am. Next, we have Dr. Neetu Ahirwar, ma'am. Ma'am is associate professor GMC Bhopal. We welcome you, ma'am. Next, we have Dr. Padma Shukla, ma'am. Ma'am is president at Reva Obstetric Society. We welcome you, ma'am. Next, we have Dr. Palak Bansal, ma'am. Ma'am is consultant gynecologist at Lucknow. We welcome you, ma'am. Next, we have Dr. Pallavi Singh, ma'am. Ma'am is associate professor at GMC Bhopal. We welcome you, ma'am. Next, we have Dr. Ranu Jain, ma'am. Ma'am is assistant professor at Jabalpur. We welcome you, ma'am. Next, we have Dr. Sona Singh, ma'am. Ma'am is associate professor GMC Bhopal. We welcome you, ma'am. Next, we have Dr. Surbhi Singh, ma'am. Ma'am is secretary at Rudrapur Obstetric Society. We welcome you, ma'am. Next, we have Dr. Vibha Mehrotra, ma'am. Ma'am is secretary at Kashipur Obstetric Society. We welcome you, ma'am. Now, I request Dr. Priya, ma'am, to start the panel discussion.
Yes, thank you.
Thank you.
So I hope my screen is visible.
It's visible.
Yeah. So today I'm going to keep it very simple. So it is a venous thromboembolism panel. We'll be having a series of cases starting from a little bit on antenatal, covering most of both the venous as well as pulmonary embolism, and little bit touching upon on the postpartum as well. So we all know incidence of venous thromboembolism, though it is documented little late, but it is one of the major causes of mortality, not the DVT per se, but the undiagnosed DVT leading on to pulmonary embolism. It is one of the major causes of mortality. And now, now the venous thromboembolism, we know that it's increased more than like 5 to 10 folds, and almost 70% of these cases can occur antepartum, and they are evenly distributed. And inherited thrombophilias have been identified in more than 50% of the cases, and 50% of these pulmonary embolisms can occur postpartum and mostly within the first 2 days. So why is pregnancy a hypercoagulable state? So any of my panelists, you can just take it. So why do you consider pregnancy hypercoagulable? Anyone?
Can I reply this?
Yes, sir. Yes.
Because pregnancy is a coagulable state because the coagulation factors are increased, and also the anticoagulation is also decreased. Like the register for the protein C is more, so that's why it's not correcting the anticoagulation, and also fibrinolysis is also decreased. So all the three factors acting in a three-way that increases the coagulability.
Yes, sir. So very rightly explained. So what is the risk of mortality? And this is the data from NHS, and they are like, compared to our state where we still have PPH and preeclampsia to be the most common thing. For them, the first common reason for their maternal mortality is cardiac disease, followed by the second most is the DVT. So that is why they give more importance, though it is 1 in 1 lakh. For them, the second most common reason for mortality is still there, and it's worldwide also, it's more common. Should we assess the risk for the patient? Any patient, pregnant patient coming to a clinic, should we assess a thromboembolism risk score for them? And if we have to assess, when should we done? Yes,
May I take this question? Firstly, I would really like to thank Monica ma'am for making me a part of this amazing panel and discussion today. And it was such a wonderful experience listening to Charmila ma'am and Sarveshwari ma'am. Moving to our question, that should we assess the risk for venous thromboembolism in pregnancy? We should assess the risk for all patients given the contemporary times that we have a billion lifestyle disorders, obesity, and high BMI. Also, a lot of patients come who have taken up infertility treatments, ART. So they're high risk for OHSS. Along with that, we might have patients who have already had a previous episode of venous thromboembolism. So we should, start with assessing the risk in the first antenatal checkup itself. And if possible, even in the prenatal checkup and the prenatal counseling, we should assess the risk for venous thromboembolism. I am not sure if this is known that FIGO had come up with a concept called the pregnancy passport in the last conference. They had released this thing which documented each and every risk factor that a patient can have. For example, their weight, their BMI, and like their past history and whatever happened in their previous pregnancy.
That's very beautiful. Can somebody mute Dr. Priyanka ma'am?
Please.
Ma'am, yes, thank you. So very beautifully told, yes, and it should be ideally done even in pre-conception period if we have an opportunity. If you have a ART patient who is already on the obese side, and nowadays we are seeing more than 100 kg patients, BMI 40, 45 are very, very common nowadays. We initially, I don't know, maybe some of the seniors can opine who have a practice of 35, 40 years. Before that, have they encountered this BMI of 40 and 45 before? But now I think at least one patient in a month comes with that kind of a BMI yet. So, we have to document that, and like how we come for Just-Osis, put the Just-Osis score in the first visit itself. Same way, also make a DVT score also. And if the patient is high risk or low risk, document there, and definitely a lifestyle measures will be of help. Yes, so you have to do it at booking and reassess them. if they have an increased weight gain, if they develop preeclampsia, if they develop something, add-on risk is there, and then reassess them during at 28 weeks, intrapartum and postpartum. Okay. So why we assess, I think we have already answered that. DVT is like, a known risk factor is there. And what they have found in studies is that almost like whoever patients have got DVT, and only 67 patients have a risk assessment. So almost like many patients, they don't even have a risk assessment, and they are the patient they land up with DVT. So they said you get the risk assessment and put them on thromboprophylaxis. So, and and the one of the most common reason for DVT in worldwide is being not prescribed adequate thromboprophylaxis. One is fear of bleeding. For example, the patient has PPH. We think that, okay, she may bleed. So that is one. And the second thing is we give inadequate or incompletely assessed risk, and that are the reason. So now we'll go on with the case. A 36-year-old, a primey, married for 10 years, BMI of 32, ART conception, now with twin gestation. She had hyperemesis. She was admitted twice during this pregnancy. Last admission, she was discharged 1 week back. She's traveling through a flight from Dubai, a 4 to 5 hours flight, and at 16 weeks of gestation to the mother's place. Now she complains of bilateral pedal edema. Left side is more obviously swollen than the right. So now, what are all the risk factors for her for DVT?
I would like to take up this question.
Yes.
I'm Dr. Ranu Jain from
Yes,
Jabalpur,
ma'am.
Madhya Pradesh.
Yes, ma'am.
Ma'am, if we go for the risk factors for DVT, she falls into the criteria of her age being more than 35, then
Yes.
her BMI more than 30, then
Yes.
she has an ART conception, she's having twin gestation, she's having hyperemesis, and she has traveled. So traveling again is one of the risk factors. So she comes under the criteria of very high risk for DVT. Like we say that 4 low risk factors should be there, or 2 transient risk factors should be there for her. So she comes under that, and she's giving us a classical complaint of limb pain. So we have to keep DVT as diagnosis in our mind, and
Yes.
we need to
Suppose this
further
patient has
evaluate
not
her.
had DVT. She has just come to you at the 16 weeks. No leg edema, anything, you assessed her. So what will be your advice for her?
I would like to investigate her,
No,
madam.
no DVT, no swelling, nothing. She has just come
Ah,
for checkup, and all these history, these risk factors are already there.
yes,
They're
yes.
risk factors. So what will we do
So
for this?
with keeping all these risk factors in my mind, I will like to go on a basic Doppler for her, that she might have a high risk of developing this, but she is at
Yes.
present now 16 weeks.
Yes.
So I have to keep her into vigilance, and I have to give her thromboprophylaxis.
Yeah, that was my question. Yes.
Yes.
So when will you
So
start?
that she
What?
doesn't develop, because she already belongs to the high risk.
Yes. So what will be like, if any other panelist is there, what will be the thromboprophylaxis if at all we are picked up before the DVT? What will we advise her? What are all the advices we can give for this kind of patient? Because this is
Avoid dehydration, ma'am.
yes,
Avoid dehydration
yes,
and keep mobilization frequently.
okay.
And we can go for the ultrasound Doppler, lower limb Doppler, ultrasound and color Doppler of lower limb.
Okay,
Ma'am,
thank
we'll
you.
have
We
to
have high.
put her on low molecular weight heparin according to
Yes.
her weight. If her weight belongs from 50 to 90, a baseline 40 mg will be there. If she's more like her BMI is high, she might be
So
her
ideally,
BMI is
this
high, then we have
patient
to go
should
to
have
60
put.
mg.
Got it.
And irrespective of her gestational age, we have to continue her low molecular weight heparin till
Completely agree
full
with you.
gestation.
Yes, so this kind of patient, she had a risk factor. If you have encountered her before a DVTs happen,
Yes.
ideally we should have started her on thromboprophylaxis whenever you have come when the first visit itself. So that is the there, and now we know, she has got it anyway. Like now we are going to treat her. So is there a role of Wells score? So anyone have any idea about what a Wells score is, and is it a role in pregnancy?
Ma'am, as such, pregnancy mein there's no role of Wells score.
Yes.
We have developed a different screening factors, different screening criteria. So we can give, if a patient have more than 4 or more than 3, different guideline like RCOG, ACOG, CEPOC guidelines. So we can follow them. Some are point, some are having a graded point. So हम accordingly उसके start कर सकते हैं madam, patient के risk factor के accordingly. But this
Yes,
Wells
so
score
this
have no
is
use.
for non-pregnant women. We don't have a role in pregnancy. So now coming back to our case.
Ma'am, here I would like to add,
Yes.
if we go by Wells score in pre-pregnancy,
Yes.
then it might give us a clue कि भाई ये patient को कुछ ना कुछ तो there is a high risk. So
Yes.
she might land up. So we cannot every time just exclude this score. There is a utility, but I can say that there is a utility in pre-pregnancy more rather than in pregnancy.
Yes. So now this coming back to our patient, she has edema. So what will be the investigation which we are going to give it to her? Anyone?
Ma'am,
Investigation.
ultrasound color Doppler.
Yes.
Ultrasound
So
and the color
ultrasound
Doppler.
color Doppler. So that is the gold standard. If suppose, a patient is, we're thinking in terms of pelvic DVT, what are we going to do? If it is
MRI
not-
pelvis, ma'am. MRI pelvis, less
Yeah.
radiation exposure.
So this is, like in short form, like they've given it as Lenny. Initially they said for DVT diagnosis by Lenny. I thought there is some test which we didn't know, and then it is given as lower extremity non-invasive testing. So if somebody comes and tells you whether you've done a Lenny, it is nothing but the color Doppler which people have mentioned. Yes, and if it is suspicious of your DVT to be extending into the pelvis, then definitely order for an MRI.
But here we have one glitch, madam, that MRI should be recognized with that PCP-NDT Act, because that here the problem of PCP-NDT comes to us because pelvic DVT we cannot diagnose by any other means except from MRI. But lower limb Doppler, almost 80% of the things
DVTs
are
are picked
covered
up.
up. But in pelvic part, it is not possible.
No,
we
sorry.
need
I
to-
didn't understand, like when you, madam, you came and mentioned about PCP-NDT and MRI.
Ma'am,
What is the link?
MRI center should be registered with PCP-NDT Act. Then only we can subject our antenatal patients for pelvic.
I think most of the
No,
centers.
ma'am, we can do nowadays. Yes,
No,
it is
no,
necessary
all
with
the
PCP-NDT.
MRIs, I want to add here, all the MRI centers, they must be registered by PCP-NDT.
Yes.
That's
Exactly.
mandatory.
Yes.
That's mandatory.
And definitely all the MRIs will have scan also. They will have a basic ultrasound. And even if the scan is for echo, it has to be registered under PCP-NDT.
Yes,
It's a
ma'am.
cardiology clinic.
Exactly.
Only echo is being done also. It has to be registered. It is compulsory. So any ultrasound machine cannot come to anybody's clinic without PCP-NDT Act. So,
It is mandatory, ma'am.
it is mandatory. So
mandatory.
that is no question at all. So any MRI center will have a basic ultrasound. I don't think anybody can have exclusive MRI without an ultrasound. So anyway, they will have it. So it will be registered. So is there a role for D-dimer in DVT?
D-dimers are usually increased in pregnancy. So in a non-pregnant female, they would have some significance, but in a pregnant female, they would hardly hold any importance because like D-dimers are anyway raised in pregnancy.
Okay. So I'll leave it to that. So now how are you going to do that? So what is the plan of treatment, or how do we treat a patient with DVT? Anyone who's not answered?
Ma'am, if we are suspecting DVT or we have high clinical suspicion, then we can go for ultrasound. अब अगर ultrasound भी positive आता है, ultrasound plus color Doppler, then we go for the direct, we start the anticoagulant therapy as per the protocol. और अगर हमारा clinical suspicion high है and ultrasound negative है, then we can repeat the ultrasound on days 3, day 7 onwards as per the high risk score.
Yes. And if for clinical suspicion, we have a low suspicion, we are not thinking in terms of DVT, it's just an edema. So then we just leave it, we don't treat it. So that is very clearly said that. Okay, we'll go on with the next case. A primary 25-year-old PCOS patient, a BMI of 28, she's a spontaneous conception. She has a history of DVT after taking ocipils for just 1 month because she's a PCOS patient. And because she had irregular cycles, they gave it, and she has a family history, I'm sorry, for which, in an uncle, DVT in an uncle, and stroke in the mother. But she was not given any long-term medication after the acute treatment is done. And there is no records is available. Now she's coming to you at 7 weeks for booking. So what will be your advice for this patient?
Ma'am, we should start thromboprophylaxis.
Yes. So what is your what do you think when the patient comes with a history?
मैम अगर पेशेंट को कोई अनप्रोवोक्ड एपिसोड है लाइक एक्सेप्ट फॉर द मेजर सर्जरी अगर है देन वी avoid it. If the patient have provoked because by OCPs or any estrogen containing hormone pills, then we can advise the patient is prone for development of VTE, then we should advise her as a thromboprophylaxis.
Okay, so we are thinking in terms either it can be hereditary or it can be acquired thrombophilia, which is APLA. Yes. So for this patient, when they have family history also, then we are thinking in terms of inherited because it is like, thrombophilias are there. Okay, so when do you require or when do we advise these thrombophilia testing?
Before pregnancy.
Yes, because most of the thrombophilia, sometimes there'll be like little bit of changes during the pregnancy. So we advise ideally before pregnancy. And in APLA, we know part of the APLA can be done during pregnancy as well. So that is there. And once the patient with inherited thrombophilia, is it like, low molecular weight heparin? What is the dose? Or is there any difference of what we give for these patients? What is the advice? Previous
patients have thrombophilias, we consider higher dose of low molecular weight heparin. In comparison,
anybody else is differing in this? All thrombophilia higher dose of heparin or specific thrombophilia higher dose, specific normal dose?
antithrombin deficiency, ma'am. Antithrombin 3.
Yes. So antithrombin 3 deficiency and your APLAs. For these two conditions, we try to give, and especially when there is history of DVT, we try to give high dose of thromboprophylaxis. For all other inherited thrombophilias, we give the normal prophylactic dose of thrombophilia doses. Okay, so these are the things, and we usually start it as early as possible. We continue it throughout the pregnancy, and we go up to postpartum as well. And all other thrombophilias are considered as low risk. So this I think we have already covered. And for low risk thrombophilias, you can even start the thromboprophylaxis. When do we usually start it for low risk thrombophilias? When there's no DVT, no previous history of DVT, low risk thrombophilia. For example, protein S deficiency.
From 28 weeks.
Yes. So only at 28 weeks, when there is no history of DVT, for a low risk thrombophilias, we start that time. And I think this we have already told. So yes, and this is what I think somebody was already mentioning. You're unprovoked, or even if it is provoked by OCPs, you have to start it early, continue throughout the pregnancy. And anybody can comment on the thromboprophylaxis when it's provoked by surgery?
So surgery is a high risk factor. Surgery is a high risk factor for thrombosis. So if after a prolonged surgery thrombosis has occurred, that means it's a inherent risk factor for the thrombosis. That's why it's not counted as a high risk factor. It's a medium risk factor.
Exactly. So anything provoked by surgery, we will not consider it as a high risk factor. So we will not give them continuous thromboprophylaxis for that unless and until they have an additional risk factor. Very beautifully told that. So some special situation in first trimester. Anybody want to comment on that? These are the transient risk factors. So these are the two conditions which we call it as transient. One is hyperemesis, and if a patient conceives with OHSS. So these are the two times. Only during that period we give thromboprophylaxis. After that we stop. So these are that. And when do we switch over? For example, if a patient is already having an oral anticoagulant, when do we want to?
After 6 weeks, ma'am. Within 6 weeks, ma'am. As early as possible after missed period.
Yes, so within 6 weeks, we try, at the time of 6 weeks, we try to change from warfarin to heparin. Beautifully told that. And dosage, I think Madam Ranu Jain, Madam was already telling. Madam, can you just enlighten us, what is it generally, how do we give the dosage? Thromboprophylaxis.
So this chart beautifully shows according to the body weight, we have to decide. And then we have to give 60 mg subcutaneously, daily dose we have to give, and we have to continue till the delivery. And we have to either if we are planning a cesarean section or we are planning for the vaginal delivery, we can just stop almost 6 hours before uh, our procedure. So there is no risk in low molecular weight heparin. And similarly, we are opting for our
So is this
long
6 hours
unfractionated ones.
uniform for all,
Yes,
or
yes.
is it like, depending on the doses, madam? 6 hours.
Depend upon the dose. If the patient have prophylaxis dose, we can
Yes.
wait for 4 to 6 hours before surgery. If the patient had full therapeutic dose, we have to wait for 12 to 24 hours.
Beautiful,
It
very
depend.
good.
Ma'am, it is almost safe before 12. It is like
Yes,
we have
yes.
not
Yeah,
counted.
12
So,
hours, yes, madam. If
yes,
it's a therapeutic dose, that means
yes,
therapeutic is double the prophylactic dose.
yes.
So if the patient horror, almost like 75% of the prophylactic dose. So high dose prophylaxis for patient is there. Then we try to give a little more wider window, more than 6 hours. Otherwise, even 6 hours is good enough period for us to say safe to go with surgery without bleeding risk. Yes, completely agree. So now we are going with the next case, 32-year-old second gravida. She has come at 28 weeks of gestation. She has sudden onset dyspnea, pleuritic chest pain, and along with that, mild hemoptysis. There is no fever. Family history: the brother had stroke, father had DVT. On examination, heart rate 122, BP 100/60, respiratory rate of 28, saturation is 90%. RS is clear, no V's, and unilateral calf tenderness is there, and leg edema is there up to the level of thigh. So what is your diagnosis, or what do you think with this picture?
So here the symptoms are suggestive of preeclampsia that is supported by the family history and also the clinical features and the features of the
Pulmonary
examination.
embolism.
Pulmonary embolism, all are suggestive of pulmonary embolism.
Yes, so all the typical features she's having, like the pleuritic chest pain, palpitations, along with that, respiratory changes and ECG also. So, fine. So, why do we think pulmonary embolism? Because we already gave you family history of stroke is there, and pregnancy itself is a hypercoagulative state. Any patient having a lung symptom, first DD will be a pulmonary embolism that have to be ruled out. So, other than that, is there a role for D-dimer in pulmonary embolism?
Yes, in the years algorithm, there is some role of D-dimer is there. Although in the pregnancy, D-dimer is there is a lot. In the third trimester, it increases a lot. But still, if all the features of years algorithm, 3 features are there: signs of DVT and probability of pulmonary embolism is there, and edema is there. Then we can go for the D-dimer test. Depending upon the D-dimer level and the 3 features of the years algorithm, we can whether we have to go for CTPA or we can as such exclude the patient from the further evaluation.
Okay, got it. Yes. So there are 2 types of studies which have been there. One study endorses D-dimer and says it is the test. It has completely value, whereas the other study says no, it has no values. So we have not had a clear role of D-dimer on the pulmonary embolism. Yes. So once we have done that, again when we have leg edema, we will go with Doppler. And then what are all the other methods to diagnose pulmonary embolism? Anyone?
CT pulmonary angiogram or ventilation perfusion test. Yes, ma'am.
So as it is mentioned in this chart as well, if a scan shows DVT and the patient has chest symptoms, we need not even confirm. You can just start with the treatment as well. So that is what the international guideline says. But in our country, you have to prove that yes. And if you have a bedside echo, which is showing some embolism, a large emboli is seen, or if a chest X-ray shows a collapsed lung, all these are like also suggestive. And most of the a little tertiary centers will have CT scan. So CTPA is more easily done than the VQ scan. So one of that. Whenever there is a massive thromboembolism, pulmonary embolism, how do we manage? Massive pulmonary embolism. So there are two types of pulmonary embolism. One, it can be very massive. One, it can be not massive. So the changes is that whenever it's massive, if it is too big, we can even plan for embolectomy. That will be in, like with your other cardiothoracic, it's not our decision. So it is a multidisciplinary team there. And whatever it is, the same thrombolytic therapy will be started there and thromboprophylaxis will be given. So are we worried about the, risk of radiation to this baby when you do a VQ scan or a CTPA?
Although it's written there, no radiation effect on the fetus, but there is some studies are there which indicates that childhood cancer risk increases due by BQ scan. But recent studies are not supporting it.
Yes.
By CTPA scan, the chances of maternal breast carcinoma risk also increases. But it's not confirmatory. Many studies are contradicting this. So we should be cautious whether you have to do it or not, and it should be always guided by the clinical judgment.
Yes. So if the clinical judgment is strong, you go ahead and do it. That is what anybody differs. Or are we going to counsel the patient? Sir, you told us two things. One, the baby, it can be a chance of leukemias, and for the mother, there is an increased chance of breast cancer. Are we going to counsel the patient that these two can happen when we expose to radiation? Then nobody will agree.
No, ma'am, we cannot counsel them like this.
Yes, counseling, we should counsel her in such a way that her life is more important than the life of the child. And she should know what is the risk of not doing the test and doing the test. And before that, we have to make ourselves clear that is it needed or not.
Counseling.
Yes,
we
doctor.
should
When
be
it's an
make
emergency condition, sometimes patient will not understand all these प्रोटोकॉल ऑल दीज फॉलो वी हैव टू एक्सप्लेन देम क्लियरली कि ये कितना जरूरी है. अगर हमारे पास फैसिलिटीज अवेलेबल है देन वी कैन अवेल इट, और नहीं अवेलेबल है तो हम उनको इस तरह से एक्सप्लेन कर सकते हैं. पर अगर हम गवर्नमेंट, आई एम सिटिंग इन द गवर्नमेंट हॉस्पिटल, इन द मेडिकल कॉलेज टर्शियरी केयर सेंटर, sometimes patient is very from very poor class or very from illiterate, not able to understand our medical terminology. Sometimes it will be very difficult to explain that they have that much of risk of developing breast cancer or leukemia. So we can counsel them, but it is if necessary, then we can go for directly.
Yes.
I think life is more important than explaining the risk, future risk.
Completely agree with you. Patient's life is more important. But yes, there is a small chances that these two things can happen. We are not totally neglecting that. But in this situation, when your suspicion for pulmonary embolism is very high, you go ahead and do the test or start the thromboprophylaxis, and then whenever the test is available, go ahead and do it. So that is what is the final conclusion. But we should know that there is a very minimal risk. But most of the studies have disproved that it is not there, and the radiation which is exposed is very, very small. Whatever they say is like less than 50 to 100 Gay rays is the radiation risk. That is what they are quoting for even the CTPA scans. So is there a role for IVC filter in pregnancy?
If we are planning our IVC filters, we have to do postpartum period.
Yes, yes, Madam Rani, Madam, I agree. Dr. Deepika, you were telling something. Sorry, we didn't hear you, Bill.
Ma'am, mostly when it's a iliac vein thrombosis, then the IVC filter would be of use.
Okay, so yes, I agree. Iliac vein thrombosis, the chances of you getting it as an emboli is possible, but usually we don't plan it in pregnancy because it has not been found to be very successful, and they have had more complications rather than it being useful. So we give thromboprophylaxis and we plan it after delivery. That is what is usually given in the guidelines. Fine. So if it is a small emboli, we directly, pulmonary embolism, it's not a massive, then we just give anticoagulation. There is no role for thrombolysis therapy. Okay. So postpartum, like peripartum period, when a patient is on low molecular weight heparin, she's come to you for delivery. So what are all the things which we'll do? A patient is planned for induction. So when to stop? Anyone? Low molecular weight heparin? Your patient who had DVT or pulmonary embolism, she's had throughout low molecular weight heparin. She's come to you for delivery. Can normal delivery be given?
Induction labor can be started at 39 weeks of gestation.
Yes.
And if she is taking low molecular weight heparin, it should be stopped 24 hours before.
Yes.
But ideally, she should have been switched to heparin, the conventional heparin, at 37 weeks. So in that case, we could have stopped it by 12 weeks, 12 hours before, or at the maximum 6 hours before the induction of labor. That should be there, and we should be knowing that low molecular weight heparin should not be continued beyond 37 weeks, and we should switch it to the heparin, conventional heparin.
Okay. So why do we think that everybody is recommending us to deliver at 39 weeks? Why not 40? Anyone? Because usually we want to have a planned delivery. So, like we don't want her to come into labor who's already on low molecular heparin, come and bleed on us. So that is why we have a planned delivery. So that is why we are planning her at that period of gestation. So whenever we have to give regional anesthesia, so like, for example, your spinal or epidural, what is the window which we want, like, from heparin to epidural or spinal, and then when we can, like, again reuse it. So what is the window? Anyone, ma'am?
6 hours for IV unfractionized heparin.
Yes.
And 12 hours for low molecular weight heparin.
Yes. So this is standard for either for inputting the spinal or removal of the epidural. For both insertion and this one, both are 12 hours window. If it is therapeutic doses, people say almost 24 hours, and depending on the bleeding risk. So these are there. So when do we restart it? I think we have already mentioned about that. Usually, depending on the risk of bleeding, a prophylactic dose, you can start a little early. When you are starting a therapeutic dose, we start a little late. So both as 6 hours and 12 hours. Why do we think this venous thromboembolism is a challenge in pregnancy? Both pulmonary embolism or DVTs?
Because most of the symptom. Yes, sir.
Yes.
आप continue करिए.
Okay.
Yes.
Because the symptoms are confusing with that of the normal features of the pregnancy. Because pregnant women, they may have shortness of breath, may have leg edema, and fatigue they will be having. All these things are there. And as such, algorithms are not so much helpful in pregnancy. And
True.
biomarkers, they are also not so effective. So that's why it's a challenging in pregnancy. Always we cannot go for investigation. We have to diagnose it by clinical equipment.
Yes. So this one is a patient, 36-year-old, IVF conception. She is like gestational hypertension on labetalol. She has had aspirin and she had a late IUGR. She had pre-prom breech oligohydramnios, underwent a cesarean at 35 weeks. Post-operatively, she received thromboprophylaxis for 3 days till she was hospitalized, and now she has come at 28th post-op day with the left limb pain and swelling, which is there for 3 days. So, weight is 60 kgs, BP is 120/80, pulse rate of 120, respiratory rate is 20. There is swelling up to the level of thigh, a left lower limb, tenderness over the calf and the back of thigh. So, diagnosis, I think it's very clear, DVT. Now, why does this patient develop? Because we have anyway given her thromboprophylaxis.
I think, ma'am, it is not sufficient because patient had multiple of risk factor like IVF conception, hypertension. So 3 days prophylaxis is not sufficient. We
Yes.
should give at least 10 days if the
Yes.
patient in the lower. The patient have high risk factor, more than 2 risk factors, we should give up to 6 weeks, more than.
Yes. And what are the other risk factors which could have developed? Like, other advices we give it for the postpartum women.
To avoid dehydration,
followed.
early mobilization,
Yes.
and ambulation, proper ambulation, little bit of exercise of lower limb and elevation of lower limb, like that. Patient can advise them.
Also.
Now we have to
Yes.
counsel while we are discharging that if you are developing some symptom regarding your pain is increasing or your swelling is increasing or breathlessness is increasing, you need to immediately report back.
Yes,
Now she's
because she's come at
staying
3
in
days.
yes,
I
and
think,
not
ma'am,
showing,
patient को हम
then that
patient को हम
negligent
एक
part is
proper
from the
post
patient. But we need to counsel her very, very thoroughly because she belongs to high risk, and definitely the dose you need to continue 6 weeks postpartum. So if in the we work in periphery poor patients who are not able to afford LMWH, so at least we can give shift them on warfarin so that at least oral medication she can take for 6 weeks,
Ma'am,
and
on the patient, we
we
can
need to
add
definitely follow her up.
Okay. Dr. Sona, you were trying to tell me something.
हाँ
Yes.
मैम बस मैं I just want to say that we should add the postpartum visits
Yes.
like on the day 10 after 2 weeks day 14 so that we can assess the development of any high risk factor because assessment for VT it should be continuous process like at preconception at the time of conception at 28 week intrapartum postpartum day 5 तक हमारे पास पेशेंट रहता है हम डिस्चार्ज कर देते हैं आफ्टर दैट वी शुड एडवाइज देम कि नहीं आपको इतने विजिट पे इतने दिन पे आना ही है तो
Yes.
पेशेंट को एट द सेम पोस्टपार्टम विजिट अगर हम कंपलसरी कर देंगे तो वी कैन अवॉइड दिस टाइप ऑफ कंपलसरी
Okay. So
कॉम्प्लिकेशन
one small doubt I really have, like, we have a few North Indian patients who come to us. Okay. They hardly drink water, hardly
Yeah,
a glass of water.
ma'am, you are
they
very
drink.
much right.
And
And they
Yes,
don't
ma'am.
come and
use
tell us
salt,
they drink
they
water
don't
while
eat
taking bath.
food, they are only on your, we
That
call it as
laddu,
dalia,
Yes, ma'am.
porridge.
tea
Yeah,
ka laddu.
bas,
that
and they will
laddu
not
and they
eat
avoid
anything.
normal water when they
Avoid
use
Yes.
boiled water.
Yes, and they avoid water containing fruits, vegetables, nothing.
Yes, ma'am.
Absolutely nothing, no water at all.
It's a
Like,
very frequent practice in the postnatal period. I'm
Exactly.
dealing at the very remote area में मैम आप जाएंगे ना तो they avoid normal water मतलब मटके का पानी they avoid that मटका and fridge पानी and they used to consume that boiled water so वो avoid करते हैं minimum पानी लेना
like, can you change? Because we feel lactation, we say 4 liters water. They hardly drink 1 glass, but they say lactation is no problem at all. So, like, really, is it like, so different between North and South practice?
Ma'am, it's very much different. Ma'am, it's very much different race. They are very much. They are living in the different population, different world. In our North India, it's very common practice to avoid water and to remain immobilized. And अभी delivery हुई है, उठना नहीं है, काम नहीं करना, चलना नहीं है. After, especially after post cesarean, so we
They will
encounter
not
this type of
even
practice.
sit and eat. They will
Yes,
lie down
ma'am.
and
Yes,
they will
ma'am.
drink.
मैम
So
इतना
we are
मुश्किल
fed up
होता है उनको
counseling
काउंसिल
them.
करना रानू मैम इतना मुश्किल होता है उनको काउंसलिंग
It's
करना
very
उनका
difficult. It's
पोस्टपार्टम
very
पीरियड
tough.
में
DVT because of that. In your clinical practice, are you encountering DVTs because of that, or we are not seeing that much? Are we just panicking over nothing?
Ma'am, DVTs though are not very common in our
Yes,
place.
ma'am.
Maybe
that
in
is
3-4 months, hardly one patient, and that too of post cesarean, you can say. Normal vaginal deliver patient, though
Yeah, we don't know,
we
like
are
though
not
we all say
encountering.
that. So
मैम
again,
एक्चुअली
मतलब
पोस्टपार्टम विजिट
maybe
इतना फ्रीक्वेंटली
in
नहीं होता है
our
मैम
area, it must not have been there. It may be in other places. So we cannot unanimously give this statement.
so
No,
like I
we
think
are
we have
also
all the states. So tell us which is great.
we are also not having so much of DVT cases.
Yes.
Mostly we are having DVT in cases of carcinoma, gynecological cases.
Okay.
But in pregnancy, DVT is also rare in our setting.
We
not
do
so common.
get, sir, but those are related to obesity and
Yes.
again immobilization, totally bedbound. Like a patient herself is getting bedbound, no medical advice. A patient becomes bedbound
Ma'am,
and they
here
get
we have a
things.
lot of malnourished women. They are hardly 40 kgs, 45 kgs. Obesity is less here. This
That
way.
is the
Yeah,
reason we get all
maybe.
120, 150
Exactly.
kgs.
Yeah.
So
So
like
mostly when you are getting the DVTs, those patients already done cesarean section outside and they came with pelvic abscess. So or some pyoperitoneum. So the extra risk factor is added, like sepsis is added. In that
yes.
case we are getting DVTs. Otherwise, phase cases of LACS or normal delivery, we are not getting any DVT.
Okay, sir. So, like, in this patient, actually, she was treated by the physician. So, she was given rivaroxaban. So, anyone has any idea, do we use rivaroxaban? This is an anti-10A inhibitor. So, anybody has experience of using this?
No,
You
ma'am.
don't.
We
If
are
a
not.
patient comes to the gynecologist, we put low molecular heparin. If she lands up with the physician, they give you anti-10A inhibitors. That's also I could conclude from that because all our guidelines says only low molecular weight heparin. So I mean, these are common things which we have in our place. A BMI of 42, which is quite common nowadays in our setups. So, third gravida, previous cesareans, 38 weeker. She has delivered by elective section. She had a PPH. At 120, 1200 ml has been lost. So she has age factor is there, and the BMI is there, and definitely she had PPH, which is an added risk factor. She is a candidate for thromboprophylaxis. So now, 3 risk factors are there. She automatically falls into thromboprophylaxis. So cesarean itself is a risk factor. But here the dilemma is whether to give it to prevent DVT, or not to give it to prevent bleeding. So in this kind of dilemmas, what will be your take? Patient just had PPH. You know she has risk factor for DVT, but whether to give thromboprophylaxis or when to give.
Certain other devices are available, just pneumatic compression devices are there.
Yes.
Which will not increase the chances of bleeding, but that will decrease the chances of embolism.
Yes.
So that can be used. Or you can use the unfractionated heparin also, that is short acting, that can be given IV drip also, so that you can immediately stop it. So those are the methods you can do it.
Yes, so whenever bleeding risk is there, we can choose for
Ma'am,
non-pharmacological
one point
method.
here
Yes.
I would like to add.
Yes.
Since she is under very high risk, she had PPH.
Yes.
So we can, for the time being, we can very well cater with the emergency part of PPH. And maybe 24 to 48 hours after that, we can put her on unfractionated heparin.
Yes.
So that 24 to 48 hours, she can very well cope up because she was continuously on the prophylaxis, and the PPH part is very well dealt up also. So we
Yes,
can.
but in the 24 hours, usually we get very worried.
Yes.
So
Yes.
anti-thromboembolicum Stockins, we can just put it off.
Yes.
So that, the DVT, even it happen, it doesn't go as pulmonary embolism. So that is where we come with the anti-embolism Stockins, yes. And the postpartum, as we already told, if it's a low risk women for 10 days, high risk women for 6 weeks. So what is the advantage of the low molecular weight heparin over the unfractionated? Because when I was postgraduate, we used to use only unfractionated. We have not heard of low molecular, but now the use of unfractionated is hardly in any setup. I have never seen that being used unless and until you have to use it IV. So what is the difference? Why have we shifted to low molecular weight heparin? Anyone?
So here the unfractionated heparin, frequent dosings are needed. Bioavailability is less. So more the drug you will give, less it will be effective. And thing is that if you are giving more the drug, more the side effect will be there. Thrombocytopenia will be there.
Yes.
And osteopenia, HIT, these are the things are also there. So that's
Yes.
why mostly we have switched up to low molecular weight heparin.
Yes.
But there is some problems with low molecular weight heparin also. Like it's having a higher T-half. That's why it cannot be, if it is stopped, it cannot be reversed immediately.
Yes.
And we are not having any drug like protamine sulfate which reverses the unfractionated heparin. But in
True.
low molecular weight, nothing is there to stop it.
Yes,
So
sir.
those are the disadvantages.
Yes, and we need not monitor for low molecular heparin, whereas you have to do the APTT monitoring for that. So there is
Yes.
one thing to assess your low molecular weight is your anti-10A level. So do we routinely monitor 10A level, or is there specific scenarios where we monitor 10A levels?
Actually, we are not doing
Yes.
anti-XL level is not so commonly available. That's why we are not doing it.
Okay, so only when there is a renal impairment, or if a patient is having a DVT in spite of prophylaxis, then we monitor anti-10A level. Otherwise, it is not needed. Is there any specific contraindication for low molecular heparin? If at all anything is there where you cannot give, we don't usually prefer.
Renal impairment?
Yes.
Renal diseases.
Yes, ma'am. Even other than that, yes. Yes.
Thrombocytopenia, ma'am.
Yes. So these are the two things we usually don't try to give, and any unknown bleeding causes, or if a patient is having ongoing bleeding also, we will not give that. So as we already mentioned, unfractionated heparin, it's still being used. We usually give it as IV, and especially when you need a shorter window during delivery time, we try to give those things. So, and I think these are the newer drugs, vitamin K antagonist drugs or the direct 10A inhibitors. But I think the studies have shown there is no proven safety in pregnancy or the lactation. So as of now, we don't recommend, according to our guidelines, there is no recommendation at all. So is there a role of aspirin in thromboprophylaxis in the recent days? So postpartum, your patient cannot take low molecular heparin and take aspirin. Is there a role?
No, ma'am.
Yes.
There's no role.
Noted.
Yes. Yes.
Heparin, low molecular weight heparin is anticoagulant.
Yes.
Aspirin is antiplatelet.
Yes. And aspirin has a role only in some arterial thrombosis, but here your thrombosis is more of venous. It has no role much. So there is no point there. I think we have come to the end of the discussion. So if there is any one take-home point from my panelists, I think each of you can give one take-home point, and I think we'll end the panel. And I would really like to thank Dr. Monica Singh for this wonderful opportunity. And, it is my privilege to be, the same, platform as with Jayam Kannan madam and Charmila madam. Both have been my mentors. So it is a proud moment for me to, share a stage with them. Thank you, ma'am. So
Thank
my panelists, you have any take-home messages?
Thank you, Priya madam,
so
for
much.
your
Thank you, sir.
nice conduction of the speech. Sorry, not speech, the panel discussion. And one take-home message is that we are seeing so many of antenatal cases, but never we are assessing the risk for thrombosis in all the cases.
Yes.
We are very much fortunate that we are not having so much thrombosis, but many of the cases we are seeing where they are having 3 or 4 risk factors in them. So we should having the intuition in our mind, and we should see them, and we should calculate the risk factors so that we can be prepared for the thrombosis or pulmonary embolism in those cases.
Yes.
That is the
Thank you, sir.
Thank you so much, ma'am. Thank you, ma'am, for a wonderful presentation and connection with us. And I think मुझे ऐसा लगता है कि we should add postpartum visit, compulsory postpartum visit. This should avoid development of complication within 6 weeks. 1 or 2 visits in the first 42 days of delivery. Thank you, ma'am.
Thank you.
I just want to thank you, Madam Monica, madam, who include me in this session. So thank you so much, ma'am.
Welcome, most welcome. I want to give one message, Dr. Priya.
Yes, ma'am.
The message is that we are, rooted in traditions and cultural bindings. I think Tamil Nadu, after hearing the maternal mortality, the dramatic lowering, and the type of socio-cultural economic changes which are happening in Tamil Nadu, you are now progressing towards a more affluent and educated society. So obesity is also a measure of that.
Yes.
As affluence increases, the obesity also increases. So in our limited resources of Madhya Pradesh, especially the load of work which is there in government medical colleges, the thing we have to advise is early ambulation and break the taboos of diet. It is better to, just motivate that patient towards 2 simple things which do not cost a single penny, are drinking water and walking early.
True.
They are absolutely free of cost, and this can only happen when the clinician is connected with the patient in the postpartum period for at least 24 hours.
Yes,
For
ma'am.
24 hours postpartum, there should be at least 6 hourly visit by clinician. आपने कितना पानी पिया, आप कितना चले. You know?
Yes. True.
Yes.
Very
I mean,
true.
that is the only message I can give. Because
Yes.
Thank you, ma'am.
yeah.
So, Ranu ma'am, you want to say something?
Ranu
Thank
ma'am,
you so
Ranu
much,
ma'am, you
Monica
were the
ma'am.
star of today. Ranu ma'am, you were the star of today.
Thank you so much, madam. Thank you, ma'am, for giving me platform. And it is really my privilege to hear Kannan madam. It was an eye opener for all of us, madam. Really, I congratulate Kannan madam. Like every line of her was a keynote for all of us.
Yes.
And madam, here I just want to add only one thing that today, after reading so much of venous thromboembolism, I just had one thing in mind that from today onwards, I'll keep the high risk factors on my table so that it will thoroughly go on repeating in my mind that, yeah, this is a high risk. So I will have to think about it because whatever our mind knows, then we work accordingly.
Yes. There should be a
So
high index of suspicion.
exactly.
I refuse to believe that the incidence is less in MP. Maybe we are underdiagnosing. Maybe.
Maybe, madam, maybe.
Maybe. Yes.
Sometimes they don't come to us, madam. They land up with the physician's side and they don't come and tell us that your patient has come to us with DVT. They land up directly with the leg pain, breathlessness, sir. They land up with the physician's appointment and they go with pulmonary embolism, but they don't land with the obs and gyne. So that
Yes.
is what I feel. They don't come into us until it becomes a mortality. We never happen to know what happens to her after 4 weeks or 6 weeks.
Ma'am, we lose a lot of antepartum eclampsia patient in our medical college with embolism. So that could be one of the triggering factor. Maybe we will come across with some studies. Just I had a thought in my mind that there must be somewhere the high risk factor.
You know what, Dr. Ranu? Archana Mishra ma'am said that out of the 150 deaths happening in MP per month, only 20 are going for audit. Only 20 are selected for audit, which are supposed to be totally preventable. So can you imagine there is a huge chunk of 80% deaths which are happening at home, in the transit, in the periphery, in the postpartum period.
Exactly. And ma'am, we have a big tribal belt in our MP of Mandla Dindori, where it means it's very, very remote area there. And patients, all of us come to Jabalpur because we are the basic tertiary center attached to that place. And for them, the delayed referral, delayed transport, they literally land up uninvestigated, unbooked to us. So we need to really work on that platform a lot.
No, I think we can make a change. I think this has started, the change has started with the perception. Dr. Archana Mishra has attended this meeting, so it's very good. She's going to now start a committee. In that committee, we will be having Charmila ma'am and Jayam madam, who have voluntarily agreed to help MP. And every now month, we will forward 4 case sheets to them. We'll form a WhatsApp group. So Ranu ma'am, if you want to join that WhatsApp group, and Dr. Arun Kumar is in AIMS Bhopal.
Yes,
Dr.
ma'am.
Arun sir, if you want to join that WhatsApp group, and
Yes,
we
ma'am.
will volunteer to study the case sheets, forward them to Jayam madam and Charmila ma'am, take their inputs, and then put the measures into the general mainstream. So
Out of the 20 cases, every month discussed, we are having 5 cases at least from our hospital. So
Yes.
that's why I will be happy to join this.
Yes, so I will start the proceeding with Dr. Archana Mishra very soon.
Yes,
And
any
thank you.
help is there, we are all there to help you, ma'am. No issues at all.
Totally need your
Thank
help,
you.
Priya, because you have opened her eyes to so many things, that things can be done. See, you are India, we are India. Then
True.
why are we so much behind? Okay, we are 1,000 kilometers away.
What the Kerala and this one Tamil Nadu they did was, they did not involve only the people in Post and Foxy, madam. They involved the general practitioners who want only patient care but no societal platform. They just involved them into this kind of a place to educate them, and they went to their own community to teach them.
And
It
one
worked.
difference in Tamil Nadu and in Kerala, what I heard, the bureaucrats are, in sync with your opinion.
Yes.
Here,
Made
bureaucracy,
it like that.
yeah, here
It
the
was very
bureaucracy.
difficult, and now we have made it.
So we have to approach the bureaucrats in such a way that we get a positive response. And I'm sure they will also help. This is a platform which is on record, so we cannot give discredit to anyone. We have to go with bureaucracy. We have to go with medical colleges. We
But
have
once we start with that, once we have understanding, and it is about helping and to improve the overall state rather than stopping the blame game. It is possible. Sometimes even we tend to do, madam. Initially, everybody will be like that only. Oh, that place, they would not have done properly. We are doing properly, but now the changes come. Okay, sit and analyze what has gone wrong.
What I was thinking was, even after such a lot of tremendous change in your maternal mortality, still 6 months back, an IVF conceived 35-year-old was taken into labor for 20 hours of induction.
Madam, sometimes I'll tell you, no, madam. When we listen to the patient too much, we
yes.
lose it.
Yes. So
Okay, it is not that no doctor would have wanted to wait for 20 hours for an IVF
Yeah, they
consultation
don't
and
give
get it.
consent actually, madam.
So there are a lot of
They are
patients
very
who take the
reluctant,
decision in their
and
mind.
when something happens,
we
then the
should
whole blame game comes on the doctor.
Yes.
That is the main issue, ma'am. And in private,
Because
we are
even I'll tell you,
bound
one of
with
my
the
friend
consent.
had a mortality, madam. For them, what happened was she had a HELLP syndrome, and it was a smaller setup. They wanted to refer them out. Patient said, "Today is not a auspicious day. I will go tomorrow only. I will not leave your setup." And this doctor, she should have forced, put her in an ambulance and sent her. That is the only mistake she didn't do. She agreed to the patient. She referred it as a late next day. It was a late referral. The referred hospital, the patient landed up with DIC. They could not do anything. They lost a mother. No, the baby survived, but anyway, it was a HELLP syndrome. It was a decision on call. They should have delivered. They should have picked her up that time. They listened to saying that it is a non-auspicious day.
Similarly, the obstetrician who traveled from Pudukkottai to Tiruchirappalli,
Yes.
40 kilometers, she lost that life because of 40 kilometers, and she did not know her diastolic BP was 150.
Madam, she had headache, madam. She ignored it.
She
She was
ignored-
obstetrician. She had headache.
But Priya, this is a sin.
Yes.
Having ominous features, ominous symptoms, and gynecologist not recognizing it.
And 130, 90, why you have to wait more than 38 weeks?
So these are things which are totally preventable. The only thing is raise the awareness probably.
True.
And we should not lose a doctor.
Yes.
We just had a doctor who died in Bhopal 15 days back. He believed in naturopathy. His sugar went up to 150 or 250, I don't know. No, his sugar went up to 520. And he believed in naturopathy. He was against insulin. Can you imagine?
It's a very common practice, madam. Most of the people usually avoid insulin, ma'am.
True,
It's very
mortality
difficult
rates
to.
are unavoidable here, no, madam. These are home deliveries conducted by their husbands. Those every, now and then we get into the newspapers.
And there's something called wild deliveries. People want to deliver like in jungles.
Yeah.
Like the placenta should come, no instrument, nothing. I mean, it was on Facebook. So this group was banned. They found the culprit. So many people had already died by joining this cult. This is a cult here. So sometimes too much of advancement also takes you back to tribal era.
Yeah, true. Very true.
Once you become very educated, very advanced, you become very backward also. So thank you, Priya, so much. Our discussion can go, for a long time.
Sure.
And after a long time, I'm a pure IVF person. I have gone into so much of obstetrics. I had a medium-sized nursing home, which I stopped functioning obstetrics because I felt that in a small nursing home, I cannot do justice to my patients. And I do not want any mortality to happen
Yes.
just
No,
because.
that is what madam was saying. Many of the smaller setups are closing in fear of public rage and the the government's support, the way they come and blame game. So most of the smaller setups are closing down because they're scared. Why to take a risk? I think once we start working on these things, we should know which you can handle in a smaller setup and which patient we will never know when they become high risk suddenly, but at least who are high risk from the start should be referred out.
Yes. Thank you so much, Dr. Priya Kanappan, for
madam.
your
Thank
great panel, which we have enjoyed. And thank you so much to all respected dignitaries from MP government colleges, medical colleges who have joined today. You are great teachers, and I'm sure you will make a difference in our state of Madhya Pradesh. And very soon we will inch closer to Tamil Nadu.
All the best, madam. We are waiting for it.
And this is announcement for Synergy 32. Synergy 32 is on 18th of June. We are having a very, very good topic of endometriosis, medical management of endometriosis, surgical management of endometriosis by stalwart speakers, and infertility management of endometriosis. Then the Synergy 33 is on 1st of July, Doctor's Day. The topic is to be announced. Thank you so much for loving Synergy, and thank you for being with us. Thank you, Dr. Vishal. Thank you, Mintaz. Thank you so much. Good night.
Thank you.
Bye.
Support team, please end the meeting.